who's the interim medical director at Kettering. So they'll be joining us for that item. Any declarations of interest? I have a declaration of interest. I have a very sore throat and I have a distinctly dodgy voice. So I apologise in advance if it becomes a bit irritating. The minutes of the public board meeting on the 30th September, are you happy to refer record? Good, thank you very much. The matters arising in the action log, I think there's only one item, which is the thing about drop-in seminar booked for 7th of December for non-exec directors prior to next CPC on ICANN. So that's already, should be in your diary. You should have the diary invitations. See what I mean? Sorry. So, patient story. We do a patient story every month. This is a video, and it's focusing on a patient with some learning disability, mental health issues in a pre-recorded video. It's we had a listening event for LD patients in October, and communication became a key theme. Both negative and positive aspects were talked about, and things are being changed to cope with the feedback. But we had a young patient, Amy Harrison, 21-year-old, who has autistic spectrum disorder and tells her story of living with autistic spectrum disorder and her particular communication needs, and just shares her experience about being admitted to as a patient over Christmas. It's a good, worthwhile watch. So over you go, on you go. Sharon, I presume you're actually introducing this.
I think you've done a great introduction, Alan. I'd like us to listen to the video and I'd like to make some comments afterwards, if that's okay.
Okay.
We can press play, please.
So ASD, or autistic spectrum disorder, is a condition that affects me in the way that I find it really difficult to communicate with others. I find that I have quite a flat effect on my voice. I find that I get quite a lot of anxiety when it comes to having to communicate with others, because I find it really difficult to read other people's emotions. It costs me a lot of energy in order to move around on a day-to-day basis, going to work and socialising with others. So every day I have to make sure that what I'm doing today won't impact on what I need to do tomorrow. So I have to constantly be thinking about what I'm doing, when I'm doing it, how much energy is it going to take, and how much time will I need to recover. So that's why I only work 3 days a week. If I was to work full time, I would have to also then have a full-time carer, because I wouldn't be able to cook for myself, wouldn't be able to clean, I wouldn't be able to study, I wouldn't be able to do any things that I enjoy, do any hobbies, go visit family or friends, because that would take every single bit of energy out of me. But I'm glad, because I found a really good balance in my life, being able to work 3 days a week and live by myself, and be able to keep on top of all the chores and everything like that. But that's something you have to develop throughout your life. It's not something that comes naturally. Christmas 2020, my whole family caught COVID, and I didn't think it would really affect me, because I'm young, I haven't got any kind of pre-existing conditions, didn't really feel very well. But I didn't feel like it was anything too serious to begin with. But then it gradually got worse. So I ended up in A&E. They were really quick in seeing me, and when I was in triage, my mum was let in with me because of my ASD diagnosis. They explained that to her, because at the time the rules were not allowed any visitors at all, but they let her come in with me and sit with me while they were sorting me out, which was really great, because I had no capacity to talk or explain myself at the time. My mum had to leave. I think that's when kind of the problems started, to be honest. Throughout my whole life, she's been able to, and still she does, is advocate for me and talk on my behalf. I think it was that first night where I found myself quite distressed. So I'd called my mum. This was Christmas Day now, I think, and she was trying to get in contact with the ward the whole time. But I think because it was bank holidays and Christmas, she found it really difficult. There doesn't seem to be anyone that could communicate with her on how I was doing. There was this just lack of communication on the whole, and I couldn't communicate for myself because I was so poorly. You know, I don't have the capacity to communicate very well in general, so obviously when you get poorly, you know, that reduces my ability even more. So I really needed her at that point to be able to communicate on my behalf, but it just didn't seem possible. So I did feel like there was a lack of communication due to the fact that it was Christmas, because when my mum had contacted them afterwards, they said, well, usually we'd have this patient outreach and that patient outreach and this communication thing, but it was Christmas, so we didn't. And it's like, well, it's no good for me because I'm there on Christmas Day. I don't think anybody wants to be there on Christmas Day. I just think it highlights the fact that you still need those things in place over Christmas. And I think that's what a lot of my issues stem from, was the fact that it wasn't during the week. I was sick over a bank holiday weekend, and that made a massive difference, and I just don't think that's really good enough, to be honest. One of the things that I mentioned to my mum that I would really appreciate is that if I had the curtains drawn. There was one nurse there, I can't remember her name, but she talked to my mum and she let me have the curtain drawn all day, and that was great, you know, because that really helped my anxiety. I didn't feel like there was people watching me. I felt like I could call and talk to my family without being listened to. But then obviously she went home. You have the night nurses and then you have the day nurses, and that just wasn't communicated. The next night I was quite stressed out and anxious, and I'd let my mum know, and she'd rang the ward. This was in the middle of the night, and they gave me medication to help me calm down. It could have been solved so easily by just drawing the curtains. They shouldn't have resorted to giving me a medication to help me calm down. I think one of the most important things is just ask the person that you're looking after is, what do you need? Because if someone asked me what do you need, instead of assuming what I needed, then I think a lot of my issues could have been resolved immediately. You know, if you just ask me, then I can tell you, but I don't always have the capacity to be able to bring those things up. You know, I don't want to come across as argumentative. I don't want to come across as ungrateful. So I'm just going to sit there until someone does something, because I don't want to be seen as a burden on anyone else. So if you ask me what I need, maybe give me some time to think, because at the time I might have not been able to think of those things. Ask my mum, ask me, and then come to a plan where there is actually some very simple things that could be done, because, you know, it could have caused a lot less issues and problems.
Thank you, and I'm really grateful to Amy for being open and sharing our story with us. The listening event which we held both gave us positive and negatives, but I really wanted Amy to be able to share her story wider. Her experiences were when we were at the peak of COVID, but equally there are some really clear lessons for us to learn, and I'd like to reassure the board that we are taking on board the communication challenges that have been posed within the patient story here. We're going to be using this patient story wider across the organisation as part of our education sessions, and we're going to be keeping in contact with Amy going forward, as she's willing to work with us and help and educate our teams. Thank you, Alan.
Okay, thanks, Sharon. Any comments or thoughts about that at all? I mean, I think the general question about how acute hospitals look after mental health problems or patients with mental health issues, and how the mental health services support acute hospitals. You know, it is a bit about special skills in this, and it does seem as if the collaborative type of work doesn't seem to be firing on all cylinders to our best advantage when it comes to mental health. Simon.
Thanks, Alan. I was very much agree with your point. We have an opportunity as we design the ICS to think about, again, about what mental health services should be available to those patients in acute hospitals. And I think the story that we've heard today is a powerful reminder that we're often dealing with a lot of patients who have needs, and those needs we are not always able to accommodate. We need to be honest about that, and we need to be, I think, quite assertive as we go forward into the space of designing the mental health collaborative in the ICS as to support there and to do justice by the story we've heard. We need to represent that story in the collaborative space, I think. So I'd just like to, I think it's a very different type of patient story, but one that I think, Sharon, is really valuable. And I'd just be interested in your reflections, if you could, about what practical steps we are going to take to try and address some of the issues that were raised. And also, if you have any further reflections on where we might be, where we might need the help of our partners. Thanks.
Yeah, let's just hold that. So Denise and then Heidi.
Yes, thanks, Alan. I mean, totally agree with everything that's been said, and I personally found that very humbling. I think that I agree with the comments that have been made in particular about those patients that have different needs and perhaps support from mental health. But I think it's also important to focus on the fact that this sort of situation doesn't just apply to those patients who are in that situation, and there will be other patients who are not necessarily dependent on other partners of ours, but that are our patients who don't necessarily suffer with mental health issues, who also we need to make sure that we're listening to everybody. So I just think we need to be careful that we're not kind of pigeonholing this into that category. Thank you.
Heidi.
Thanks, Helen. So on Denise's point, I think that's a really good point around how we make sure we treat everybody as a whole person and respond to all of their needs. So I agree with you, Denise. But the point I was going to make is I've linked with, and it's in the early stages of discussion, linked with David Mayer at NHFT as one example to talk, and I think it goes both ways. How do we make sure we're proactively managing mental health when a patient's in an acute setting, but vice versa, so that we reduce multiple admissions and complexity of pathways for patients? So how we support NHFT for managing acute conditions when they're in receiving mental health care. So that's something that both of us are really committed to moving forward.
Thank you, David.
Yeah, sorry, I was trying to find the the mute button. I think the point about communication and communication on Christmas Day, for example, the fact that the patient didn't seem to be able to get what she needed, I think that rings true with me, because I had a family member who happened to be in hospital on Christmas Day and on bank holidays. And it was a completely different experience than any other time in the week. And it kind of reminds me of an initiative that was in the NHS a number of years ago, which was called 7-day working. I just wonder whatever happened to that.
Okay, Heidi, is that an old hand? Okay, Sharon, do you want to come back on the broad thrust of those comments? You're still muted.
Sorry. Your final comment, David, 7-day working is certainly 7-day working, and it shouldn't matter what day of the week it is. The standard of care that we should be offering our patients should be absolutely consistent. I think as well, the points that colleagues have made thus far have been really helpful and pertinent. And, you know, there is some collaboration starting with ourselves and NHFT, looking at how we can develop and grow the number of mental health nurses within the organisation and create better links as well, pulling in as needed. And I think it's really helpful, as I said at the end or the beginning, was the work that we are doing with our safeguarding team, with our learning disability team, as to how we can increase awareness of this particular group of patients, but every group of patients' needs, and the fact that communication always needs to be clear and robust. And even when visiting wasn't permissible, which it wasn't last Christmas, we are going to be facing a more positive Christmas this year, I'm absolutely certain, and we will have visitors within the organisation, which I think will help our patients' well-being.
Okay, thank you very much. I think that was quite a worthwhile conversation. It was a good video. It's quite, Denise said, quite humbling. So we look forward to some reports on how that work is progressing, just across the spectrum of mental health patients in the acute trust. And taking Heidi's point, I'm perfectly happy to have us think about what the reverse of that looks like. And your hand is still up, Heidi.
I think it was just to acknowledge Karen is also taking some of this forward in the mental health collaborative. So there is some work that we could potentially report on at another time, if that's helpful.
Okay, thank you very much. So, Chairman's report. Well, the good news, particularly for non-execs, is we have two new non-execs joining us. We have Professor Andre Ng, who is the Professor of Cardiology at Leicester University, who will be joining us as the Leicester University rep on the 1st of December. And following the interviews, which we did a couple of weeks ago now, we have appointed Elena Lokteva from the 1st of January. And Elena's background is very much in finance. She's a qualified accountant. Actually, as she pointed out to me, she's a qualified accountant in 3 countries. So I think her background in financial deals in a variety of cultures is quite interesting as well. She's worked in the Middle East and she's worked in Scandinavia, and she now works in the UK. And her interest is obviously in that area, but in much wider area of audit and of performance metrics. She is also the chair of audit of St Andrews Healthcare. So subject to the usual checks on fit and proper person and so on, Elena will be joining us on the 1st of January. I'm sure Heidi will be talking about the Chief Operating Officer appointment and the interviews we went through last week. Since we last met, Toby Saunders has been substantively appointed as the ICS Chief Executive Officer. And on that point, the Healthcare Partnership, as it's known, and a cracking number of 3-letter abbreviations running through this, but the Healthcare Partnership, as it's known, will actually transform into the Integrated Care Board in January, and be in shadow form as it moves through January, February and March, as it becomes the substantive organisation for planning and organising health services in Northamptonshire from the 1st of April. So there's a lot to be done in that. And we wish Toby well, and we're thoroughly looking forward to having our 2 new non-executives. Simon.
Thanks, Alan. 2 main things to talk about today from my perspective. So since we last met, obviously, it will have not escaped anybody's notice that the NHS has been pretty constantly in the headlines around emergency care pressure up and down the country. So the first thing to say, I think, is a huge thank you to all our staff across Northamptonshire who are working in whatever guise, in whatever way, in the emergency care pathway. The demand that we're seeing is significant and it's countrywide, but they are the people who day in, day out get up, come to work and help keep everybody going. So it feels really important to start by saying thank you to them. Thinking about Northamptonshire a little bit, there's a couple of points I'd like to make. So the first one is, and Heidi will talk about this, there's more that we need to do ourselves. And I won't say anything more on that because that really will be the subject of some of the comments that she'll make. The second is that as a system, the Gordian knot that we have thus far failed to cut is this issue of discharges. And now we come to it again, and we come to it post-pandemic, and we come to it with exactly or similar versions of the problems that we had before. But the effect of the pandemic has been to lens and accelerate those problems. So whereas before we had a workforce problem in social care, it's now accelerated with the impacts of COVID vaccinations and also the rates of pay, frankly, that social care staff currently attract. We really do now need to think very differently about what it is we're going to do. Because the truth, I think, of the situation that we face is that it's not just a winter problem. The problems that we've now got run well beyond winter. And I think we'll have to think about the type of jobs that we offer people, how they are created, the organisations that host them, amongst other things. We do have more than enough beds, more than enough resources in Northamptonshire to decompress our hospitals. But at the moment, we still have trouble getting access to those for all the reasons that I have just been talking about and some more. Thirdly, we know that in actual fact, more investment in our urgent and emergency care services will be needed. Heidi and I have been pressing regional colleagues to give us, for example, funding to support the development of an urgent treatment centre in the NGH estate, because the reality is that we know at the moment people continue to vote with their feet, continue to come to our front door. We will need to find a way pretty quickly to decompress our estate if that's what's going to carry on happening. And to be honest, I can't see much change occurring in that pattern of behaviour for the foreseeable future. So to end on that section, thanks again to everybody who's working in our emergency care estate. It seems almost too trivial to say thank you, but I know I speak on behalf of all of us in the board when I say how much we appreciate what you do. We're also going to look at the future today. We're going to consider our clinical strategy. And I think that's a really important moment for us, because one thing that we really do need to do is to start to think about where are we going to be in 3, 4, 5 years' time. Organisations that tend to stay focused in the here and now are ones that don't start planning for the future. And we have an opportunity now, partly in the context of the ICS, partly driven by the formation of the group, that a real chance for us to think about what we can do differently and better. I referred to Bernadette's story in my report, and we've all seen that now, but the point I wanted to make, I suppose, and I made it recently at our meetings, is that there are many more Bernadettes out there. There are many more people by whom we can do better, by whom we can improve services. And we're going to have a chance to start considering some of those ideas today. It's obviously hugely important that this document that we consider today, it's our view of the world, but we now need to go out and engage with people and hear what they have to say and hear about their ideas for services. We have indeed heard some of those ideas in our patient story this morning. But it's easy, particularly in the challenging times that we face, to end in a sort of council of despair moment, but I don't want to do that. I do think we have the opportunity to be ambitious and forward-looking in this strategy, in our engagement with patients, and I think we should be genuinely proud of some of the ideas that are contained herein. So as I close, I want to thank particularly Matt and Rabia for their clinical leadership of the process to date, and to Polly for her stewardship of the work that you see here. Thanks very much.
Okay, thank you very much. So just to put a little bit more pressure on our exec directors for the course of the meeting, since we're talking about the big problem of the day being decompression of the hospitals and the ability to drive through some elective care for which people have been waiting far too long, perhaps when you talk about your items, whether that's the digital strategy or the investment pattern or whatever else, you might just spend a little bit longer than you might have planned on how that's going to make a difference to the decompression question. And building on Simon's Gordian knot analogy, which I just really love stories about Gordian knot, then instead of picking away at the damn thing, you have to behave like Alexander and take your sword and slice it in half. So I'd like to encourage you to have some rather dramatic thoughts on what you can do to shift the problem of patients, several hundred patients sitting in our hospital who really shouldn't be there for their interests and for our interests. So just a little bit more thought about how you might talk about that during the course of the meeting. Thank you. I'll take Heidi's comments now, and then we'll have any comments across the piece at the end of that. Heidi.
Thanks, Chair. To follow on from Simon's to thank staff, I can't start without acknowledging the continued pressures that teams are working under, and acknowledging the excellent support that they're giving each other, and that they're really stepping up to the plate to the point you're making around decompression, which I'll go into, but to genuinely thank everybody for, as Simon said, getting up, continuing, coming to work, and really making a difference to patients and each other. So one of the things, as Simon referred to, is the continued pressure at the front door in ED, which obviously patients experience through the long waits, but that is a symptom of the patients that remain here, that don't need to be here, and us needed to decompress, to your point, Alan. So one of the key points I said last time was my priority was around moving forward on the discharges. So I'm delighted to report that we have taken, so Rob Hicks, one of the Deputy Medical Directors, has moved forward with this piece of work with our support, which I've obviously detailed in the paper. But it's essentially, as executives, we've been on the wards supporting teams to really understand what needs to be unblocked, to really support them, empower them, be more visible, and to really make sure patients have a really clear diagnosis that we're working to, and when they no longer need an acute bed, that they are able to go home, and be really clear that when patients are in an acute hospital and they don't need to be, that isn't the best place for them. So delighted to report that it appears to be having a positive impact. We've had more discharges than we had been having each day, and from a national perspective, the data over the previous few weeks, not totally down to board rounds because it started before that, is showing an improving picture on 7 days, 14 days and 21-day stranded patients. So that's a positive, but we need to keep it going. On top of that, and I want to thank the executive team for their support with this, and everybody who's embracing it on the wards. But on top of that, I'm working really strongly in the system with Stuart Lackenby, our DAS, and really, to your point, Alan, what can we do to not just chip away at this, but to really kind of tackle it head on in terms of what can we do to support social care, work with mental health teams and ourselves. So there's things we need to continue to do internally to make sure our appetite for risk, for example, our processes are where they need to be. But very current discussions with Stuart in the system around how can our workforce plans right now really improve to recruit people to work across the system, and deal with the very obvious staffing challenges in social care, but also what can they do to make sure that there are even more going to happen in the board round initiative in terms of social workers coming in to work on the wards with us, for example, to make sure the education of our teams is really where it needs to be and that they're as empowered as they can be. So in summary, it seems to be working. It's very early days. We will continue it, but we will continue to ramp it up to make sure that we are doing everything we can internally to decompress, and equally working in the system. So I'll report more on that next board again. As you say, it's Alan, I'm delighted to report we did have some interviews to replace our coup, and we've successfully appointed a fantastic candidate called Palmer Winstanley, who brings a lot of talent to work with us. He currently is in King's Hospital. But he obviously has worked at other hospitals and has a really strong background, which we feel will add a huge value to us as an executive team. So we're delighted that he'll be joining us on the 31st of January, hopefully. So that's really positive. Another thing to acknowledge is we had a Royal College of Physicians visit And the formal feedback was very positive in terms of thanked our tutors, particularly Dr. Binns, for their phenomenal support. And largely it acknowledged the phenomenal teamwork we've got here at NGH. However, it did highlight some continued work we need to do to strengthen our medical staffing. And Matt, myself and Hemant are supporting teams with those additional measures that need to be taken forward. And obviously we welcome the external perspective, which is always really helpful. On another positive note, we are really successful and the only trust in the country to receive 2 Royal College of Midwives awards. We received Excellence in Maternity Care during the global pandemic and RCM Race Matters Awards. So can I thank the teams for their hard work and dedication in receiving those, because obviously the work is something that's been nationally recognised, and to receive 2 is fantastic. We've also had a Health Education England review in surgery because of some concerns that had previously been raised. We haven't had the formal feedback yet, but and that visit was on the 11th of November. But the initial feedback was that it had been a remarkable turnaround. So I think we should acknowledge and thank the teams in surgery for their hard work responding to the concerns raised. Last week, we had a health and safety executive team visit inspection. It covered infection prevention and control and our response to COVID, musculoskeletal areas and violence and aggression. So it's quite a thorough inspection. I want to really thank all the teams, particularly Sharon, Paul, Tracy and Claire from an executive perspective, but all the teams that work with them for that. Initial feedback, we haven't had formal feedback, but initial feedback was that we won't be getting any enforcement notices or improvement notices, but there will obviously be recommendations which we welcome and we continue to work with them. Finally, which isn't in my report, we've been successful in securing a Rainbow Badge Phase 2 support from NHSEI. So Dr. Steve Corrie-Bass and Andre Gore, who you'll know very well, is taking that forward with NHSI next week. So to congratulate them on that as well. So, so they're the main points that I wanted to raise really today, Alan.
Okay, thank you very much, Heidi. The Health Education England report is particularly pleasing because that was an area of some considerable concern. You'll remember we had some board presentations from people involved in that. Anyway, comments or questions or further congratulations or any large swords to slice Gordian knots are welcome. No? Okay. Still no? No. Okay, thank you very much. Integrated performance report, and this will be followed by, obviously, by the update on the metrics. So this should be the last time we have these, this model, if you like, and we should be into an integrated and common approach between this trust and Kettering next month. But we'll come to that. So if you could take it forward concisely and bring to the attention of the board those things you want to bring to the attention of the board. QGC, Jill.
Thank you, Chair. QGC met last week, and there are just a few points that myself and the committee members would like to bring to the board's attention. One or two will be touched on elsewhere, but first of all, infection prevention and control. We did have a long discussion about the acquisition of COVID of patients within our trust and how that's being measured and how the team are working really hard to make sure that the numbers are diminishing. We had a report from Sharon after the meeting which showed us some benchmarking. Some trusts are at 0 at the moment, and some are still having quite large numbers where patients are acquiring COVID within trusts, despite all the infection control measures. So it's something that we're focused on. Also, Clostridium difficile. We've reached 30 this year, and our ceiling set by NHSE is 35 for the year ending in the end of March. So again, keen to support the team to continue the good work that they're doing. And the health safety executive visit that Heidi mentioned really supported the fact that the work is good and that we are striving to do our very best in these circumstances. So that was really helpful. The second thing was safeguarding. And again, to continue the theme of discharges, we continue to have adult safeguarding concerns raised about us following discharges. So I think the team are very focused on making discharges and making quality discharges. So we're looking forward to seeing those numbers fall as well. In addition, for a number of reasons, the children's level 3 training for safeguarding has unfortunately slipped even further to below 70%. Again, the team are working hard to try and support clinicians in this busy working environment we've already mentioned, to make sure that they are appropriately trained. So another focus on that. Some good news on maternity services. I mean, Heidi's already shared some good news, but in terms of staffing, we made a bid in partnership with Coventry and Warwickshire and Leicester for some international midwives. And we were really pleased to hear that 9 international midwives joined us in January. So that's very positive, over and above the staffing establishment that we have already. Sickness is falling, and we've also recruited 2 consultant obstetricians in line with the Ockenden report that will start with us next year. So that's really pleasing news going forward. We're looking forward to our new Ipr Metrics, which you've referenced, Chair, and a new reporting framework next year. So we're able to look at the quality of performance as well as the other clinical quality issues that we always look at. And finally, we had a very constructive discussion around the corporate risk register about how we could perhaps present it in a slightly different way to make it really clear what the biggest risks were and make it easier to read. So that was well received by Claire and her team, and we've already had some feedback after the meeting. That's it for now, thank you.
Okay, thank you. I should have handed this bit over to Heidi to run, so admitting my error and putting it down to disease. Heidi, run this bit for me, please.
No problem, Alan. I thought you'd let me off lightly. Thanks, Jill. Matt, Sharon, is there anything you want to add in the interest of only exceptions and what you need from the board today?
I need to take my report as presented and happy to answer any questions.
Okay, so any questions from anybody on this?
I'm really sorry, I was just waiting to come in. The only thing to add is that our mortality as measured by HSMR has not been updated because Dr. Foster are having trouble running their data at the moment, but it remains better than expected at 94, and our Hsei has dropped into better than expected at 96, which is a positive development. Everything else that I would have covered on the medical practice overview has already been touched on by others. Thank you.
Thanks, Matt, and it's important to acknowledge the hard work that's gone into that, so thank you. Any comments or questions on this section? No, so we'll move on to Denise and Mark for the people section, which I think actually may have been missed out of some of the papers, so apologies for that.
Okay, thanks, Heidi. If I start, and there are a number of things that I'm going to cover that either have or will be covered in the meeting in different levels of detail. So as already referenced, we are seeing that the ongoing pressure is taking its toll on staff. So absences are increasing. We're currently running at around 6.2% against a target of 3.8%. Turnover is creeping up, and that's not something that we've had an issue with in the past. It's still not above average, I think it's fair to say, but the fact that it's creeping up is an indicator. As a result of that, the statutory and mandatory training is behind. I mean, Jill's referenced this. We highlighted the fact that we were lacking evidence in safeguarding in particular, and the delays in the infection control training. Again, that there's some clear triangulation here between what's been discussed in the different committees, and we're also behind in terms of appraisals. We had a very constructive discussion around this, and are encouraging the colleagues to look at as many different approaches as they can. It's not an easy conundrum to solve because you know, it's totally recognised that there is ongoing pressure here, but we're just encouraging people to look at things a bit differently. And if the way we've always done it isn't working, then we need to sort of try and come up with different ideas. So that was very much a focus. We also touched on, but didn't go into any detail, and I don't know, Mark may have more detail for us today, the fact that obviously we will also be dealing with the fallout from the COVID vaccination issue in terms of staff who are not fully vaccinated, not being able to operate on the front line. So awaiting further information on that, but that will clearly impact on staffing, A, staffing numbers, and B, staffing pressures. Agency staff costs, obviously a regular feature both on that and the Finance and Performance Committee. So it's under very close review, and again, some of the things that we've that have been put forward to help to try and resolve this, such as the joint staff bank. We did set a deadline for that to be up and running and fully implemented by the end of March. So that is I know, a very ambitious deadline, and it's not going to be easy, I think, for Mark and his team to get there, but we all recognise that that's really important to have a deadline on that, and hopefully that will help. People Pulse survey, I think the only additional discussion around that was in terms of encouraging the focus on local resolutions and moving, not just sort of looking at the broad brush approach, but making sure that we're sort of pinning down in those areas where things need to be addressed. And I think we're hoping, and again, Mark may confirm this, we're hoping to get the next one out in December. Following on from that, the staff survey, again, I think Mark will have an update, but at the time of the committee meeting, completion rates were still quite low on that. So it's we're not running as high as we were last year. I think the last couple of things that I want to say is firstly around performance measures. So as a committee, we've been operating as a joint committee, I think, for longer than any of the others. So we've had our performance measures in place for a little while. So we're having a bit of a review of the performance measures. We're looking at, are they working for us as they are? Do we need to change things? And we're putting a particular focus on outcomes and impact. So there's a lot of really fantastic work that goes on, and a lot of really hard work that goes on from the people. So we need to make sure that all of that activity is really having an impact on what we need it to. So we're having a quick review of the performance measures. And finally, volunteering, which is one of the key arms of our strategy. A great story to tell there. Increasing volunteers, a broader range of duties, and therefore, more impact on the hospital and the staff who are not volunteers. There will obviously be a good impact on them as well. The more volunteers that we've got in carrying out wider range of duties. Thank you.
Thanks, Denise. Mark.
Thank you, Adi. Thank you, Denise. That was hugely comprehensive. So that's pretty much everything that I was going to talk through has been covered. I think there's a couple of things, one or two things that I would just mention in the board. And again, apologies for the narrative not being circulated. We'll put it under admin control as soon as we finished here. But we also had a System Health Service Journal Award nomination, to which we attended last week. Unfortunately, we didn't win the award, but we were nominated as a system for our virtual health and wellbeing event. And so for me, that was a demonstration that we are doing as much as we can and will continue to do in regards to health and wellbeing for colleagues. But as Denise has articulated, it's still having an impact on, we're not having an impact on our sickness absence position, which continues to climb whilst people are under such significant pressure, and we continue to look at alternatives to support them. I think it was very important to mention the COVID vaccine and the mandation of the COVID vaccine. Lots of people, because of the announcements, have centred at this in terms of April. We've set up a task and finish group, and we're working through our information, trying to understanding who has and who has not received how many doses or not of the vaccination, because for colleagues who are in service roles that are deemed as frontline, we need to have vaccinated them with their first dose by the 3rd of February 2022. So we're working through that very quickly. We set up a weekly task and finish group around obtaining our information, our occupational health provision, and indeed supply of the vaccine, all of our recruitment materials in terms of how we're recruiting contracts based on this new change in legislation. And of course, Teresa's supporting us in and around communications around that effect too. So quite a significant amount of work being undertaken with regards to that aspect. I think it's important also just to update on policy progress, as my narrative would have. So I committed as part of the people plan that we would also in Q3 start to look at how we join up some of our policies. And I'm really pleased that one that's a front runner for this, excluding the disciplinary policy, which has already been completed, is our job planning policy. I think that's really impactful one, and a later agenda item with regards to our clinical strategy to make sure we're consistent across both Northampton and indeed Kettering. And that's pretty much it. The only last thing that I would leave us with is that we have our Excellence Awards this evening, and we wish all of those that have been nominated and shortlisted all the successes of winning. But I have to say, there's some fantastic nominations. So despite all of the pressure that we faced during 2021, it's still really important to hold on to the fact that we have some outstanding colleagues working with us. Thank you very much.
Thanks, Mark. Any questions from anybody on the content that Denise and Mark have covered? No. Thanks, Mark, for acknowledging the awards. I should have said that in my report because there's been some amazing nominations. And just to assure the board on the start and mandatory training that Denise referred to, we have already taken some executive work forward to make sure we're prioritising, making sure that the areas we need to be most concerned about have clear actions. So working with Mark and team on that, and Tracy. So thanks, Mark. So moving on to Andy now for the group digital update.
Thanks, Heidi. So you'll see there's an update on the digital strategy later on. So what I'll try and do is not overlap the two things. So key things we discussed as a committee was the update on the digital strategy. We also talked about the framework, what good looks like, and that's a framework where we'll be assessed for our digital maturity as a trust and at an ICS level over the next few months. We discussed an initial self-assessment, and the initial view is that there's although we are still digitally immature, there's quite a few things that we will be addressing through the delivery of the digital strategy, and identified one or two gaps that are not covered by that we'll pick up. There is actually a national survey on the way at the minute, which is around EPR usability experience, and that's communication's gone out across our hospital to encourage our clinicians to have their views. The more information that we get from that, the better we get analysis we get from a national level, and also help to shape our EPR programme as it develops. And the other thing that happened on the committee, we had a demonstration of the patient knows best. That's the patient front door that's been selected for our ICS, and the pilots that will take place later on in this financial year around early care planning and maternity. And I think some really encouraging things there around giving patients access to records and communication methods and various information that will just help their journey. We also talked about robotic process automation and the Centre of Excellence. Just a reminder that we're one of the 2 Centres of Excellence nationally for robotic process automation. The committee challenged the team to report back with a more comprehensive proposal on options for how we might take that forward. So moving from centrally funded into a more sustainable position, which we will obviously take back. And an item that is on later, but I think it is worth mentioning, is we celebrated the fact that we got to the end of the NHS.net migration for NGH, and the last few people left who are still using the Teams platform will complete completed in the next few days. and then that is all done, and we're using the same email system, the same Teams platform, which will help our collaboration no end. Thanks, Heidi.
Thanks, Andy, really helpful. And here it's important to acknowledge the NHS.net migration, thank you. So any questions for Andy or comments from anybody? No, okay. Thanks, Andy. So we'll move on now to finance and performance and bring in Rachel, John and Matt. Thanks, over to you, Rachel.
Thanks, Heidi. So we're in the fortunate position that we only had F&P yesterday, so even I can remember what we discussed. And probably even more fortunate that John managed to hand us a good set of results, with year to date only being $500,000 behind plan. In terms of the drivers behind that, we're in the, we have the good fortune to have had a significant amount of ERF income, but against that are the increasing pay costs, where the understandable pressures of vacancies, sickness, etc., are driving those higher than we would like. And John, correct me if I'm wrong in any of that. In terms of what else we went through, we had a good discussion on the H2 plan. In terms of, I know it's coming up later, so I'm not going to repeat it, but we have submitted a break-even plan. It's a system plan, and I'm not going to go through it all because John will, but we tested the assumptions, we thoroughly kicked the tires. It's going to be one of those ones where whatever numbers we run through, we could come out with a whole heap of different outcomes. But actually, I think we've got a sensible set of assumptions on finance and activity. We've got a sensible appetite of risk, which is fairly low. And a lot of it is going to depend on, as Simon and Alan alluded to earlier, the ability to decompress the hospital to deliver this and come out the other side relatively intact. The other thing I want to bring up is the discussion we had around the electronic patient record. I know that it's dragging in Northampton, but we do need to find a way to resolve this. There is a request for an increase of 3.9 million more on the business case. We've got to find a way to move this forward and to stop any delays. I think that's fair, Andy, isn't it? It's holding us back, and it's something that we really do need to progress. John, Matt, Andy, any comments?
Yeah, shall I
go for Andy?
If I just sort of respond to that, yeah. So yes, just to pick up on that point, so the business case, as part of the feedback from the national team, we were asked to look at the range of costs that could materialise out of our procurement, and that has resulted in an overall increase in cost of £3.3 million, which, you know, as part of the discussion yesterday, and there's some further work on the back of that. I think what we need to acknowledge is that's accommodating a range of costs, and you know that this is part of the process that we need in order to meet the business case criteria. We are still optimistic that we'll end up at the lower end of the cost, very much near the original business case approval that we talked about back in April.
Thanks, Andy. So if I just add my kind of 2 pence for that, having not been part of the original business case that was discussed at boards, I believe in April of this year. So Andy and I have agreed how we need to work together to kind of push this over the line. I think the important points to raise to the board are how we would provide assurance on how we manage those costs down. And Andy and I have discussed about how we might be able to do that, and those trade-offs, because there will be inevitable trade-offs. And then moving forward into planning for our new financial year, essentially what that pre-commitment on resources means for us in terms of our ability to do other things. So Andy and I have had a conversation post F&P already to work through how our teams get to the bottom of those numbers and can present a plan that provides that level of assurance that's much needed to be able to progress it. and we'll come back to the board and our plans to do that in due course. On the finance performance bit, so thanks Rachel for the summary. I think the only piece to add there is a relatively technical one, and that is that at the time that we reported our month 7 financial performance, we hadn't actually agreed a plan. That isn't because of our doing. The planning process for the second half of this financial year, which we'll get onto later on in the board agenda, was finalised after the date that we closed the books for month 7. So we will in month 8 have a little bit of a catch up in terms of just correcting and restating some of the numbers, because we've got to a better position than we had expected to do when we reported at month 7. So nothing to flag to the trust board in terms of risk to those numbers at month 7, but just saying we'll need to do some tidying up because our plan evolved from the time that we closed the books at month 7, and we'll do that in month 8.
Thanks, John. Matt, do you want to add anything?
Thank you. Just briefly, because what's been said, it will be fair to say that October was a busy month in terms of non-elective attendances, certainly the highest in the last 12 months, and that was mitigated largely through a reduction in conversion rate, and thanks to the improved and increased activity of the same-day emergency care amongst our initiatives. But that did put some strain on our ambulance handovers in particular, which is an area which is an organisation we normally perform pretty well. We had a brief discussion yesterday also about our stranded and super stranded numbers, which had been, as we've in many other organisations and due to the multiple pressures that we have been discussing, been drifting in an unfavourable direction, and it is a great credit to the work led by Liz Sargent among us, and also perhaps an early dividend around the board rounds that we are starting to turn those numbers around, as Heidi has also referenced. We did not discuss in detail because it was picked up in the Quality Committee the week before the cancer situation, but it is probably worth highlighting to board that there was a 24% increase in two-week referrals in September, which is of course now feeding through to a level of pressure in terms of treatment delivery. Despite that, we have maintained the 28-day faster diagnosis standard, and we have escalated oversight and capacity to attend to that. And just to close on a moment of the good news, we have continued to reduce our 52-week breach position, and I would like to say a personal thanks to Hemant Namade for stepping up into quite a large proportion of the medical director's portfolio to enable me to offer some support to ops. Thank you.
Thanks, Matt. Given I didn't introduce this, I did miss some of what you covered. I was going to cover at the beginning. I think it's important to acknowledge the pressures that are at the front door, and I did cover it in my update briefly. The work that we are doing, and Simon alluded to think of and push forward on anything else we can do to decompress and equally keep ED as safe as we possibly can. So the urgent treatment centre, as Simon referred to, is something we're trying to progress to with colleagues from the centre. But I did want to at the beginning acknowledge, Matt, for your unrelenting support to me since I've started in post, and the fact that you stepped into the space of being the coup alongside the board medical director, and to thank Hemant because it hasn't been easy for you stepping into that space, and I can't thank you enough for your support. So on behalf of the board, I'd really like to thank you formally and Hemant. So just sorry, going slightly off tact there, Alan, but I didn't manage to do it in the intro. Moving on to CPC now. Oh, has anybody got any questions, sorry, on that section? No. So moving on to CPC now, I'll hand over to you again, Rachel and Simon.
Well, we have a section on this later, so I think it's probably important to leave most of the talking till then. But actually, we did cover some subjects in a lot of detail, such as the clinical strategy and the academic strategy, both of which I think we're going to talk about today. Simon, anything to add?
No, thanks, Rachel. I think we've got a good chance to debate these issues later on, so I would suggest if board colleagues are content, we do that there.
Thank you.
Thanks, Rachel and Simon. So thanks, everybody. Any questions before I hand back to Alan? No, so I'll hand back to you, Alan. Thank you.
Okay, thank you very much. I think, Matt, you have a promising career as a coup if it ever goes wrong as medical director. Right, IPR metrics update. You'll recall that this was a challenge I gave you in the summer to get ourselves to a common set of metrics between us and Kettering Hospital. And that sounds like a simple thing to do, but Andy will bore for England and how difficult it was, really. But nevertheless, we've made a lot of good progress. So Andy, if you'd like to take us through what's agreed as a pretty tight set of metrics for the IGR going forward from January.
Thanks, Alan. And hopefully you can see that I'm sharing the right screen of the metrics. Okay, so I'll just jump through this because we've been through this a number of times, and I just wanted to loop back to the board and just confirm where we got to through the committee cycle. As you know, that we had two separate IGRs, IPRs across our group, very different sets of metrics and even different ways of measuring the same thing along the way. So we've had those discussions over the course of the last few months, and just a reminder of how we've got here. So we've been through the committees, and a discussion audit was the latest committee. And so we're now in the process of developing these different sets of metrics through the what we've been calling the fire break process. So the metrics will not only be available in the board packs, but also on the Power BI platform. So colleagues can actually look at that in month, or refer back to it, or even do some comparison between year on year as we go through. So we're heading towards providing those in the January board. So I'll just give you a bit of a summary of all the metrics, and this is just a recap. So previously we had 57 metrics that were in the IGR. What you'll see now is the number has gone up here in total. However, so there's 89 in total. However, if you look how they split down, we've got below the target that Alan set around to get below 50 for the metrics. So there's a good collective effort there, and you'll see that there's a number of metrics spread across the different committees. So those 89 are covered in entirety across the committees, and then rolled up to have the 45 that we talk about as a board on board sessions. So I won't jump into the metrics. I think we've gone through it in the committees, and happy to take some questions at the end, but I'll just sort of come back to where we've got to. So just to note that I think the music stopped now, and we've got to that initial set of metrics, and the way forward is to start using those in anger through the committee process in January, and then we'll continue to iterate those, and then we will do a formal review at 6 months' time here at board to see how that's going and how folks have found it.
Okay, Andy, thank you very much. This has all been through the process several times. Are we? Any comments or thoughts about it now as the final go-to? No. Oh, Jill, yes.
Thank you. I'm really looking forward to having the new IGR metrics in the Quality Committee. I just wondered, as it wasn't in the paper explicitly, Andy, is there a process for committees escalating things across to other committees so that we're not just working in silos? So, for example, although we didn't have the paper in the Quality Committee this time, we did discuss the pressure on ED and the elective waiting list and so on, and talked about the potential for patient harm. And the same would apply to the People Committee. Are patients at risk if we're not reaching mandatory training levels, etc.? So is there a process or some consideration around a process as to how we can escalate things across to different committees, or is that just through the board?
So maybe if I talk at a metrics level, and Claire might want to sort of add around the governance side of things. So the 89 metrics will be available to every committee. So it will be that ability to jump into those elements that are perhaps outside of those core parts, and that gives the capacity to look at that. And obviously, because it's going to be available on Power BI, colleagues can look at that in advance of the sessions or as those numbers develop as well. In terms of how that jumps between committees, maybe Claire can make sure I say the right thing.
Well, I think it's about the chairs making sure that we can make contact with each of the chairs and keep people updated. But if there is information that is going to be shared, it's down to individuals to make sure they look at that information and then can highlight any issues as and when they arise. I mean, as we haven't seen it yet, it's difficult to, live, haven't seen it working live. It's difficult to comment on how well that will work, but I'm sure it's something that will be iterative and we will work together on.
Thank you.
Denise and then Heidi.
Yeah, thanks, Alan. I mean, this is more from an informal point of view, but I guess when we've got the new board members in, then maybe if we sort of look at who's on which committees, because one of the things that we're finding helpful at the moment is if you're on more than one committee, then you can take the information from one committee to another. So I'm on People Committee and I'm on Finance and Performance. So I can sort of take those things across there. So I think if we sort of, when we're looking at who's on what committee, then maybe have that in our minds anyway. And also, I mean, I'm the last one to suggest additional meetings at all, but one of the things that informally Rachel and I have talked about is whether it would be good just to get half an hour where the chairs of all the committees have a half-hour informal sort of discussion about along the lines of what's keeping you awake at night, if you like. So that sort of does that triangulation. So I think we can do it without loads of sort of organisation and process being put around it.
Heidi.
Thanks, Helen. Just to acknowledge what Jill and Denise have said, it's definitely something we need to strengthen, as Claire said. But the point I was going to make, Ellen, on Andy's paper is this not only improves the position at board from an IGR perspective, but it will help us really strengthen how the divisions work, how we respond to risk, and the Power BI developments that Andy's described will really empower our clinicians to have data more available for them and for them to respond. So this, I just wanted to acknowledge, this isn't just about what we receive. This is something about really strengthening the culture of ownership and accountability throughout the hospital.
And finally, Andy.
Yeah, so I was just going to loop back to the comment from Denise around new board members. I think one of the things you've highlighted is something we've tried to do is making data count refresher sessions, and I think it would be worth doing a review of that based on the new committee members and running that perhaps just as a roll-in, do it every 6 months, and then anyone who feels they need another go at SPC charts can join in.
Okay, thank you very much, guys. And I think you'll find the step change into SPC charts saves a lot of debate about things that aren't real. We all get excited about a slight improvement, and in fact, it's nothing more than random variation. So we ought to be much more rigorous. But I suppose my point is wider than that. I mean, this set of metrics is actually a kind of nexus that brings together a whole load of things below it and above it. So below it, Heidi's right, we talked about Power BI as a tool for data for teams and divisions and so on. But above it as well, I intend to talk at the non-exec director away day about how we can increase the rigor and the compare and contrast elements of committees in common between the two organisations, and how we can move to consistent chairmanship of those committees and consistent support to those committees, rather than having a series of 2-hour meetings and pretending they're a committee in common. So we need to make a significant change there. But I think we also, having developed that set of metrics and that set of working over what will be a series of months, I then need and then intend to take the conversation about having boards meeting as a committee in common, and we'll have to ask the individual trust boards as well how often they would feel we need to meet to fulfil their obligations. These are not entirely simple questions, they need to be thought through, and so we're just going to start that conversation off in the December session, and non-execs with responsibility in those, or execs with responsibilities in those areas will also want to have a little think about what's necessary. Heidi, is it still a hand up or is it an old one? Right. Okay, thank you very much. Now, I'm going to press on now because you're 15 minutes early and the next item 6:20. So, John, over to you for, and then we'll have the break after that, which should be about 11 o'clock. So this is about the H2 financial plan. And just to give John time to not make his coffee, but get ready to talk about it. I think the point to be made here is, you know, whilst money is always an issue in the health service, it's not going to be the driving force of the next few months. And in a whole variety of ways, money has become available to us. Maybe temporary, maybe revenue, maybe capital, whatever. But it's not going to be the major driving force. And of course, on top of that, we've just been awarded £10 million of TIF funding, which if I could remember what TIF stood for, I'd feel a lot better about it, but Andy will tell me because it's all to do with technology. And I think we just need to think very carefully about how we make sure when money is not the driving force, that what we do with that money is entirely compatible, is in fact driven by the strategic objectives. We should not be doing things that don't contribute to the strategic objectives we talked about, and there's a wide range of those. So long experience tells me that when money is not the driving force, a little bit of easing of the discipline of what we decide to do with it can happen, and I'm confident that our Director of Finance will not allow that to happen, but I'm just giving him a nudge to make sure it doesn't. This is a time when you really need discipline on what you're going to do with the money you're getting. John, take us through H2.
Thank you, Chair. Nudge received loud and clear. Just for colleagues, TIF stands for Targeted Investment Fund, and it's a process that was implemented for the second half of this financial year to essentially put out both capital and revenue funds to help elective recovery. With that being said, and the importance of seeing this stuff in the round, I'm going to defer to Karen for an intro, because we're going to do the finance and the other bits of our plan, which are as if not more important over these coming few months. So if I can pass over to you, Karen, and then I'll pick up the finance lens as we work through.
Thank you, John. Thank you. Yes, this paper presents our final submission for the plan for half two. This is a system plan, but what we've got here is the NGH element of the system plan. And as John says, and quite rightly, this is much broader than the finance. This is about balancing the three priorities around delivering our elective recovery, in particular looking at focusing on elective recovery whilst we're balancing the winter pressures and delivering the winter plans, and the focus on decompressing the hospital, as we've talked about already today. Balancing that with looking after the plans for our staff, looking at health and wellbeing, delivering our workforce plans, and then the money to delivering a system plan. So in summary, key things are that we have got a plan which John will talk to the finance. There is an element around the activity plan which Matt will be able to talk to, and Mark for the workforce. But in summary, we have a plan that does deliver the elective recovery based on delivering the same as we've delivered in half one. It does deliver a break-even plan, and it also delivers the workforce plan to support that. So I'll pause there and hand over to each of the colleagues to take us through the elements. So John, you're starting.
Thank you, Karen. So for members of the public that may be listening or watching in, I'll give a little bit of an overview about the process if it's helpful, and then I'll go on to the detail. So as Karen has said, we've developed a system plan. We have a system financial plan, and as part of that system financial plan, we've agreed that the system will, across the whole of the 21-22 financial year, this financial year, will plan to post a surplus of £1.3 million. In terms of organisations' contribution to that, the CCG will post that £1.3 million surplus in its books, and the intention is for all other providers, NGH, KGH and NHFT within our system, will all post a break-even position. From an NGH point of view, that means that it will recover the deficit that was reported in the first half of the year, circa 200k. So we'll deliver in absolute terms a surplus in the second half of the year to get to break even by year end. It would be remiss of me not to comment on how closely I've worked with other system finance colleagues to get to this point. I don't believe, and was clearly told before I came into this role, that the system approach to financial management was not the strongest element of our system working, and I think we've come on leaps and bounds over recent months to get to a place where we are comfortable with moving resources around the system to meet individual organisation and system aims, and I think that's a really, really important point to know from a system and effective working point of view. So within that break-even position, there are a few key assumptions that I'd like to pull out, not the detail that's in the papers, but the key assumptions are this. So we are assuming that we roll forward our run rate of spend as was incurred in H1. So resourcing is essentially H1 plus a few specific points. So plus some investment for specific winter capacity of about £2.4 million. That's in line with our agreed system winter plan. Plus the impact of any profiling of investments. You'll be aware that investments that we make in year normally come in partway through the year, and therefore spend in the back end of the year will be greater than beginning. We have adjusted for that. And we have also been in a position where we've been able to create a contingency of some £1 million to manage unknown or unseen pressures throughout the remainder of the year. In reality, and let's go back to the conversations we've already had, that money is likely to be needed to be able to manage us through a very, very difficult winter, and enable us to manage flexibly the creation of capacity as we need to in responding to those pressures. We, in terms of the big moving parts and why we're in a slightly better position than I suspect I might have expected to be presenting here, we have agreed to move some money around the system, some £6 million, to cover the increase in planned costs. And we have also received two other chunks of money, one for growth, which has been allocated on a national formula to the system and then down to the trust, and a separate amount of money for elective recovery, some 3.9, I think the number is, £1 million, to cover off the costs of maintaining the additional elective recovery capacity we put in at the beginning of the year, or in H1, and we agreed as a board, I think it was our last board, that we would continue to keep that capacity in to give us the best chance of delivering on our operational performance front, and that capacity is played into our activity plans. So the fact that we've been able to keep that capacity in and fund it, as well as being able to provide some not insignificant single-figure millions of investment, both for winter and a contingency, has been no mean feat. We, from an investment point of view, as has been alluded to, we were successful as a system in bidding for quite a significant amount of major investment for digital to support elective recovery, some circa £11 million. Of capital and about £1 million worth of revenue. That those funds are system funds, not a small proportion of that is directly allocated to NGH, but they are to make system investments which will benefit NGH, and those are in addition to our main capital programme. We were only notified of our success the beginning of last week around those bids. So myself, Andy, and other colleagues are working through the most effective way to both follow the appropriate governance and deploy that resource as best as we possibly can in line with the plan that we submitted to regional and national colleagues within this financial year. It's a significant opportunity. Spending significant monies like that in such a short period of time lead to challenges, and we are working through how we deliver on that. Finally, we just to confirm that we are expecting to spend our entire main capital programme of £18.9 million. That is separate to those tier 4 targeted investment funds monies that we're receiving as a system, and we're not forecasting any cash management issues throughout the remainder of this financial year. I guess if I was going to put all of that in context, we have a very reasonable position to start from a planning point of view. I think they're built on solid assumptions. We clearly need to ensure that we maintain appropriate controls, as you've referred to, Chair. But we've got a real opportunity now to ensure we've got adequate resource to manage us through a very, very difficult winter period, plus give us some headspace to begin working on how we get us into the best position possible leaving this financial year. And that for me is the absolute challenge. Back to you, Karen.
Thank you, John. Shall we take questions on this before we go on to talk for Matt? David?
Thank you, Karen. Yeah, John, just one question. Yes, it all looks good. We've got block funding, so we can all kind of break even. I suppose a couple of points here. You know, past performance is not necessarily an indication of future results, and I suppose thoughts will turn very quickly, it being November, December, to what happens in 22, 23. I mean, that's one point, and I see that's on an agenda for a different meeting today. Yeah. My question to you, though, what risks do you see in the financial position not being met, or what potential is there for the financial position not being met in 21, 22, H2?
Yeah, I think there are probably, or there are two specific items for me. Completely true. Past performance isn't a reliable indicator. However, we have limited people capacity. And I don't want to sound too much like an accountant when I say that. People don't grow on trees. What we have in our plan is an assessment and an assumption that we spend more money on people in the second half of the year to deal with our winter challenges than we did in the first part. The challenge for us is being able to manage those quite significant operational pressures within that envelope. And from a planning point of view, the numbers we've included in the plan are our constituent part of a winter plan. So I'm comfortable that we've gone through a reasonable and robust process from a capacity and people planning point of view, and our finance plan reflects that. Clearly, if we're in a position where we are spending significantly more money, and if I look at, and I'm looking specifically at rates of pay for temporary staffing, over and above the values that we've included in our plan, that will be a significant risk. I think those decisions are within our control. So that would be one of them. I am comfortable, far more comfortable as I sit here, and it's written in the paper, all of the main elements of income that are in this plan have been agreed with the people that are paying us those monies. That is not where we've been in the past. That I think should give you a level of assurance, and we have ensured that our non-pay spend, some things that have kicked other kind of organisations into a difficult position, reflects our run rate of spend at the peak in H1. So assuming we continue to deliver elective capacity to meet our operational plan in the way that we plan to do so, there should not be those pressures there. If I was thinking slightly left field, there are, of course, conversations going on around inflationary type of pressures, heating, rates, etc., utilities, and we do not have. We've got, as I said, a £1 million contingency to cover those types of pressures if they play out. We have got to do work on that. I'm not expecting those to give us multi-million pounds worth of pressures that we are not cited on. So I think the answer is a lot of the pressures that would materialise would be temporary pay related, and they are within our control to manage.
Thank you. Thank you, Karen.
Thank you, John. Matt, shall I hand over to you to talk about the elective recovery and the winter plans?
Thank you, Karen. Certainly, so colleagues will be away from the board away day development session on the 5th of November, much of this, but I will refresh and update in relation to the impact on the elective plans in H2. We are fully confident that we will not have any patients waiting over 104 weeks, and will maintain or continue to reduce the number of patients waiting over 52 weeks. Importantly, we will maintain or improve the position in relation to cancer pathways and those who are waiting more than 62 days for first treatment in particular, and will maintain outpatient capacity. Even with the benefit of the additional streams that have come online during the month, we do not believe that in H2 we will be able to reduce our waiting list as reflected in the PTL and the RTT position in complete pathways. Of course, the TIF funding and the schemes are all excellent news. Many of them, however, will deliver elective recovery beyond H2. To David's point, it will be really a 22, 23 and 24 benefit with some exceptions. So, for example, the additional outpatient capacity offered by Derby will kick in Q4. The main risks to the delivery of elective, unsurprisingly, are the non-elective pressures through winter and any additional COVID surges with the knock-on effects that they bring. The mitigations for that are maintaining the ring fence around inpatient elective capacity, and if we need for a period of peak non-elective demand to shift from inpatient to day case activity for a while, then we will do that in a managed and planned way to mitigate any impact. And we will continue to work with the independent sector. We'll also continue to work with Sharon in her capacity as a DIPSI and the surgical division as we come out of the current peak of COVID activity in our hospitals, to see what we can do around IPC guidance to improve theatre throughput, because I think there is a significant potential dividend there. In relation to non-elective modelling and inextricably linked with winter, our modelling, which irrespective of any reasonable range of assumptions we use, demonstrates that most of the time, despite the mitigations and winter schemes, we project that most of the time we will have a significant bed gap, and on the basis of the healthy financial position and the munificence articulated by John, and with the clear steer from the chair around using that appropriately strategically, we are at hospital level enhancing existing winter schemes and bringing some more practical ones on that will have impact this winter. I am supported by Bola, one of my deputies, and the divisional directors in getting some grip and traction on that. Despite which, it is nevertheless a position that is at risk through any future COVID-19 outbreaks in hospital, surges in the community, and the increase in attendance through the non-elective pathway. The main existing winter schemes that will have an impact upon this are the expansion of the same-day emergency care service and the executive-led board rounds programme, which has already been discussed at some length, and so that is beginning to see some impact in terms of the length of stay of our patients, and we will bring on board some further schemes, predominantly expanding to 7-day services around therapies and staffing models for escalation areas. I'm happy to stop there. Thank you, Karen.
Thank you, Matt. Any questions for Matt? No? Okay, thank you. Mark, do you want to just finish off with some of the people plan?
Yeah, of course. Thank you very much, Karen. So I won't take too much time for colleagues. A number of items have already been covered, such as pay and growth, which John's articulated and covered really well, including the fact that we don't grow people on trees. That is very true, John. So thank you for that reassurance. We have, there is an important change in dynamic in the labour market, which John alluded to as well, though, in terms of rates of pay. So whilst we have no more people, potentially there is the issue in terms of escalated rates across the region. And we're managing that with colleagues in other regional areas too, to make sure that there's not an overinflation, which is then replicated in other areas. We are seeing some changes in the labour market also, as you'll see, and you noted from our previous reports in terms of agency spend, in terms of healthcare assistance and vacancies in and around that. And Sharon and the team are doing some fantastic work to recruit into those posts substantively. But as we talk about at our system people board, this is an area that we're seeing more and more challenging from a labour perspective, similar to that of colleagues within social care, with industries nearby us able to offer greater incentives in terms of pay, and dare I say even now starting to move into the development space too. So the competition is much broader than perhaps it was previously, and we're working through that. I say that because it's all part of our planning across the system. I think it's really important to say that across the system we're working really closely together also from a people board perspective, making sure that we're not just managing the provider issues, but also those within primary care and indeed within social care, as I've already alluded to, and in terms of supporting our colleagues and looking, as Simon said at the very outset, the workforce that we have now may not be the workforce that we have or need in the future. So how do we look to educate people in a slightly different way that means that they can span or cross multiple institutions, as it were. Health and wellbeing, as you know, within the H2 planning is a very important subject for us. We already know all of the work that we undertake here in Northampton General with regards to health and wellbeing and the fantastic work that has demonstrated in terms of psychological support. I think I would just cement that further by that it's okay to have that in place now, and that's very valuable and supportive for colleagues. But as we move out of the break and into our future items, I think it's people look to us as a board to show them hope for the future, and that we're not just going to accept this is going to be the position forever, and we're going to look to change our pathway significantly to support them in the work that they undertake. The last point I'd like to make around health and wellbeing is that colleagues will be aware across Northampton General and indeed across Kettering as part of the group, we have provided an additional day's annual leave for colleagues to support their well-being. It's been the most fundamental request that we've had in terms of what people would require for additional support, is that of time to spend with themselves, either reflecting or to spend with their friends, family, or indeed loved ones. And we have implemented that and have cascaded that during the month of November. I'll pause there and happy to take any questions.
Okay, thank you. That's the presentation. So we all, Jill.
Thank you, Chair, and thank you to everybody for the presentation. We're very challenged on all fronts, which we've said many times in this meeting. But when you look at the regional statistics, we've got colleagues across our border who are even more challenged than we are. And we have had a discussion in various places about how we can help them. I don't know if that discussion has formulated any plans, or if indeed there is anything that we can do given our pressures.
Okay, I suspect Simon's going to answer that. Simon.
Yeah, thanks for the question, Jill. And I think, firstly, I'd just like to thank everybody who presented there. You're right, Jill, we do have our challenges, but when you think about some of the issues we've dealt with we find ourselves in a pretty reasonable position compared to quite a few others around the Midlands region, and that is in no small measure down to the hard work of everybody who has just been talking. On your specific point, I'm not yet in a position to formally update the board as to an agreed way forward, but suffice it to say that nationally and regionally, for those of you who read the Times yesterday, you will have seen there is an expectation that elective models of delivery will now be shaped to ask patients to travel to where there is capacity, because one of the main things that we know about the very significant waiting list position that we've got in the country is that it is not equal, it's not spread equally, it's clumped. And so I would expect in that context to be bringing back to the board at its next meeting a description of what we will be doing to help make sure that there really still is an N in National Health Service. So watch this space, and we will be reporting it back in the very near future. But thanks for the question.
Thank you.
Okay, thank you very much. Rachel, can I just check that this whole plan went through F&P financial performance yesterday, and that you're entirely comfortable with the assumptions and mitigations and so on?
Yeah, indeed. We tested the assumptions and we were all comfortable to support it.
Okay, thank you very much. So the board is asked to approve the trust level financial planning assumptions, and that will then become the finance plan submitted to NHSE and I today or tomorrow, I think, actually today. And that will be the basis against which we're financially performing next year. And the essence this time is not on coming in under the bar or whatever. The essence this time is getting the maximum benefit out of it as you go into the 1st of April next year. And we ought to be in a much better place on strategic objectives, not on anything else. Okay, thank you very much. You get a break, and you probably get an extra 2.5 minutes break, actually. So 11:20 back, please. And please remember, if you come back early, the chat is still being broadcast. So just make that point in case you have any conversations. So 11:20, please. Thank you very much.
So I've been playful with our team about the league table for staff survey.
Sharon, can I just check you can hear us?
Yes.
Thank you.
Okay, 11:20. You're welcome back, and we're joined by Rabia and Polly, at least in the top right-hand corner of my screen, and Kay Faulkner, who's here to talk about the academic strategy, and no doubt Matt will introduce her in due course. Right, dedicated to excellence group strategy 6-month review. We've persistently said we'd look hard at how this was going, so this is the Simon and Rachel show. Over to you two guys.
Thank you very much, Alan. I am pleased to introduce this paper, which I will take as read. I want to draw out probably 2 or 3 things. As you've already alluded to, Alan, we have an opportunity to consider 2 of our key strategies later on in this segment of the agenda. So the first thing I want to do is just to say thank you to everybody for the progress that has been made. I think when we considered this in advance of this meeting and were preparing for it, and indeed our discussion at CPC last week, it's sometimes easy to forget when you're in the weeds of the details, slogging through week after week, that in actual fact you have made progress. And I think Rachel and I, when we, and Alice as her co-chair, when we considered this, when we stood back and looked at it, wanted to acknowledge and thank people for all the effort that they have put in to get us to where we are now. So the second thing I wanted to say, and was really to start to talk a little bit about some of the promises that we have for the next 6 months, which I would draw your attention to, are on page 161 or slide 13 in your pack, depending on how you're looking at this. I'd like to start by saying, sometimes it's the little things that make the difference in bringing people together. So I don't know if you can all see, but there is my badge. So that badge is I've been the canary down the mine in this instance. Alan, I know you've often talked about how do we get into each other's car parks, how do we get into each other's buildings and not have to look like we're coming from 2 different organisations. And the badge I've been testing will allow us to do just that, get into each other's car parks, have one access point, one way of getting across our estate, which I think is a really important way of starting to bind us together. So I'm really delighted to be able to say that over the next 6 months, we will be rolling that out. You'll see there some of the other issues for your own review and reading. I'd also like to highlight on that slide our ability to start to get patients to be able to order food digitally across the 2 hospitals. One of the biggest things that people talk to us about when they're in hospital is the food and what they think of it. So getting that food offering better. I know Stuart will be working hard on making sure that will happen. We've talked too about making it easier for our staff to work across both hospitals, aligning pay, aligning terms and conditions so that we don't have to go through the awesomely tortuous processes that we've had up until now. I just thought I'd pull those 3 out as kind of promises that we need to make as indicative of some of the work that we're going to do over the next 6 months, because both for our patients and our staff, I would acknowledge, we all would, we have made progress. I am pleased with that progress and want to thank, as I said, everybody for the work that they've done, particularly as most of that time we've had COVID and all of the other pressures that have gone on day to day. But we know we need to do more and go further. And we agreed that we would do this intro as a double header, because integral to the work that we've done over the last 6 months has been the contribution of both Rachel from an NGH perspective and Alice from a KGH perspective, bringing together the work that we've been doing through the collaboration committee. And so we thought it would be, in the spirit of trying to look forward, important to have a discussion which Rachel will open out and then lead for us about, so how do we go further? How do we go faster? How do we get more comfortable? Rachel, I'll hand over to you.
Simon. I think, we did put a slide in the pack, but actually that's some detail where Alice and I felt that, there were some fairly major achievements. But actually I wanted to really talk about how it's felt over the last 6 months and how we are feeling about where we go in the next 6 months. So I think it's important to say that actually, and I do use the royal we here, and Alice and I have talked about this, and she will be doing a similar piece at the Kettering board. But I think it's important to say that it took a while for CPC to find its feet and its way forward. It's got a fairly huge audience in it, and sometimes it felt like we were slightly lost, but over the last few months especially, once we've sorted through our priorities, and especially our transformation priorities, we've started to have some really good debates about especially about the clinical strategy and the academic strategy in the last CPC. The achievement of the university hospitals is absolutely great, but it's more than just that. It's motivating for the workforce. It's something we can hang our hats on. It's something that should enable the recruitment and the retention of staff to become a real success. The collaboration between the two hospitals is starting to, we can start to see that it's actually moving now. I think Alice and I talked yesterday actually, and some of the things we talked about were that we found blockers in the most unexpected places, but actually we found progress in the most unexpected places as well. And it's about people becoming comfortable with taking risks and feeling comfortable with being able to make decisions and unblocking the real simple stuff. And also understanding that everything we do in CPC is really around supporting the clinical strategy. Simon, you just talked about the badge there. Well, it's absolutely great that our staff can do that, but actually the implications are for staff being able to work across both sites and work flexibly are really, really huge there. I think in terms of how we go further, faster, we've got to get people more comfortable with change. For the first time in the last month at CPC, we've actually started to see clinicians push to do more and to do it at a faster pace. And I think, we talked about it right at the beginning of this financial year as CPC, saying that actually we've got to get some early adopters, then we've got to get some group of clinicians comfortable with doing that, and then others will follow. I think we are at the start of that, and I think with the impetus of the clinical strategy, we will certainly be in a place where we have more people willing to take risks and go further. I think in terms of just one thing I wanted to pick up on, increasingly it's becoming obvious that actually getting people more comfortable with change is all about communication. And it's so important how we communicate out to our staff, not just what we're doing as a group, but actually how we're then positioning that group within the ICS. And, if we're going to be able to answer some of the problems or find answers to some of the problems that come up. For example, in the patient story we had this morning with Amy and in Bernadette's patient story, we've got to be able to do some thinking that isn't entrenched in our hospitals. And actually, we're going to come up against these problems, but actually the opportunities to sort these out more and more as we work within the system. So I would really make a plea to everyone, but especially our comms people, let's actually have a joined up strategy about how we make people more comfortable with what's going on. Simon, back to you.
Thanks, Rachel, for those reflections. So I think, Alan, the board colleagues are invited to accept and approve the paper that is presented. But I think both Rachel, Alice and I were interested in the discussion that or observations on the last slide. You've alluded to, Andy's alluded to, all of us have alluded to the fact that we've got significant opportunities over even in the short term with some of the funding that's now become available to us. How do we go further faster? Because as I think I've said, I wouldn't want to be sitting here in a year's time still wondering about had we spent the money, for example, on our TIF bids to change our outpatient systems. That's just one example. There are lots that Rachel's are. So I think we'd really welcome all of us with your reflections on those topics that are raised in that slide. And I'll hand back to you, Alan. Thanks.
Okay, thank you very much. Comments, thoughts? Do you agree with that's what it feels like? I suppose, you know, anybody who's read a textbook on change management knows that there's a little picture of a canyon on chapter 1, and it starts with "over my dead body." So change management is an art form, but it's a pretty well established process. And I think Rachel talking about maybe significant numbers of people moving from over my dead body to something around what's in it for me, and then even to that wasn't so bad, was it? Which is the kind of colloquial version of a change management curve. Seems to be where we're moving, and we always wanted to have early adopters, we always wanted to have enthusiasts, and we wanted to recognize them as we move forward. And that's an issue as we go into using the TIF money and using the other money. Recognize the early adopters and the pace of change we can achieve. Denise.
Yeah, thanks, Alan. Firstly, I thought great paper, really interesting, and good to see what we have done. As you said, Simon, it's very easy in amongst everything else that's going on to forget how far we have actually come. I've just got 2 or 3 observations, and none of these are rocket science in any way, but I guess some of the things that were going through my mind as Rachel was talking in particular is that I think that the language of, and this may have been Simon or it may have been Rachel, but the language of blockers. So what are the blockers here? I think that's a really useful thing for us to keep in my mind. And I think that's something that sort of over the last 12 months, in some cases, speaking personally, I've kind of struggled to get to the bottom of some of that. So I think that discipline of really thinking, if things are not moving forward, what are the blockers here, and what's within our influence and what's outside of our influence, and are we concentrating on the things that we can influence, and some of the things that we can't just have to be accepted. But I think that real understanding of where the blockers are in terms of, you know, how do we go further and how do we go faster is a helpful one. I also think, and this is really not rocket science, but I also think, you know, really focusing on time-based plans. So making sure that in the committees and in the more in-depth discussions that we're having, that we're pinning down who and when, and always have a timeline, because again, that increases the speed at which we can move. And then my last observation is really to back up what Rachel said. Communication, you know, it feels really basic, but you cannot overestimate the importance of that. And I don't think we've got communication right still in all cases.
Thank you.
Thank you.
Heidi.
Thanks, Alan. So really helpful paper. Obviously, I haven't been here for all of it. But as Rachel and Simon said, I think I just really support that this is about an opportunity to really drive excellence. So whether it's the academic health strategy, whether it's you know, different aspects of collaboration, but I think it's much broader than just the group. So you know, collaboration and working differently, as we discussed earlier, with social care and other partners is very real, and something that isn't an option in terms of how we make care better for patients. So I think it's a really obviously a fantastic opportunity for us. And in terms of the question that Simon posed at the end, in terms of how do we go faster and the cultural bit, I think that's the key around communication, because we need to start making it much more real. So whether I'm a person in the community wondering what it means for me, whether I'm a nurse on a ward, we need to make it much more real in why the group or why working across the ICS, for example, is, and what the benefits of the academic health strategy. So it ties back to community communication, but really making it real for what drives those individuals to get out of bed in the morning and come to work is something we really need to strengthen, because I think it's a fantastic opportunity and we need to make sure we harness it in the most meaningful and powerful way we can.
David, and then Rachel.
Yeah, thank you, Chair. Without doubt, we have made step changes over the course of the past year or so, and a lot of what Rachel says certainly resonates with me. The point of communication has been brought up, and certainly my conversations with not only people who I come in touch with on a day-to-day basis, but people at the hospital lead me to believe that we probably haven't done as good a job as we can in not only portraying what the group is, but what benefits it's going to bring both to staff and to people in the community, i.e. potential patients. So that's just a few comments. My third point would be, I remember when we were discussing the strategy, I mean, this must have been a year and a half back, we talked a lot about 3 to 4 major projects had to be part of what we were doing to ensure collaboration as a group. I don't see any mention of those 3 or 4 major projects. I know we've just got Becky in as our transformation manager. I presume ICANN is one of those major projects, but what are we doing about things like back office consolidation? I see outpatients as now very, very much in the profile, not only from the point of view of our hospital, but from a national point of view. I really think it's important that we begin to see traction with some of these major projects, which really are going to demonstrate that we are a group that's fully functioning.
Okay, thank you. I'll go to Becky now to pick up on that, and then come to Rachel, and then Simon.
Yeah, I was going to come in on something similar. I think there's lots of achievements that are in that paper, and I think we've come a really long way, but we've also spent quite a lot of time building the foundations to, as you say, David, go faster and bring things together across the group. So I've obviously been in post for 7 weeks, but I've had a number of really good conversations around how do we bring together the current transformation teams and the quality improvement approach so that we can bring the best of what is being done by both teams together, and making sure that programs are actually joined up across the group, and we have meetings that have both Kettering and Northampton colleagues, and that means that we can collectively go faster. And I think particularly in the group priorities around patient quality, systems and partnerships, sustainability and people, the key programs in systems and partnerships are the outpatient work, which will be accelerated dramatically with the TIF funding, which we've obviously talked about a lot. The theatres work and the ICANN programme are the main areas within that. We've done some fantastic work in NGH on deteriorating patient in quality, and that has been discussed at Group Quality Committee, and will start to be rolled out across Kettering. And there's been some fantastic work done by James and Rachel in the space of patient experience, and obviously it was Bernadette's story has been really critical to that, and the People Pulse survey is a major thing to help us keep track of what will be the programs that will help support our people. So there is a lot that's there, but I think probably the last 6 months have been about laying some of those foundations so that we can have a group approach, and you'll see some of the commitments in the future 6 months for those group priorities are a lot more substantial around delivery, and I would expect that we'll be able to really accelerate from this point.
Rachel.
I just wanted to come back to Denise on the point about blockers. I think in terms of, there are 2 sorts of blockers, aren't there? There's people's attitudes and appetite for change, and then there's the more tangible blockers. But actually, I think, we talked a little bit about the fact we seem to have got some momentum now and some understanding that actually if you take a risk, it's going to be supported. But also on the flip side, we've got the people, digital, and what's the other one? Estates strategies, and they're more tangible. But as Becky said, they take time to start to build those fundamentals. But actually, you know, this pass is such a key thing, and actually is tangible evidence that these things are starting to come to fruition, but they do take a long time. And I'm going to just say it again, it does come back to comms all the time, because actually people have got to, you know, the people in the community, patients, staff need to understand where we are. But also it does come back to the fact that a long time ago, it seems like a long time ago, when we set these priorities, we talked about actually we were going to have fewer, but make sure we deliver them. And I think we've got to give people the update and the information on where we are with those. And we've got to keep reminding ourselves that some of the other things we want to do, we're not going to be able to do to the degree we would like to. So again, it comes back to being able to give people the information and understand where we are in that journey. Thanks, Alan.
Thank you. Teresa and then Simon.
Thank you, Chair. I'm always pleased when people talk about communications in such an important forum as this. And I have to have a bit of a mea culpa moment and say, yes, the communications is not where it needs to be at the moment. We are a very new team, and we are looking at how we can do this better. One of the things we really need to do is look at our channels and routes. And I've been talking to a lot of hospitals across the region and elsewhere in the UK about how they engage with their workforce. And there's lots of things that I'm hoping to bring on stream in the new year. We do have some new channels that are in place, and we are focusing on talking about group messaging. And this is something we've learned from the Pulse survey. But we are looking at what people are saying to us, and we are looking at how we can change our methodology. But it isn't going to be quick, I'm afraid. And I'm just asking you at this point if you can bear with us. We are putting a lot of effort into making sure that we communicate group messages, particularly at the moment. And we're learning as we go. As I said, it's a new team. They're working together as a group. It's a new environment for them. And some of them are finding it a little bit more challenging than we'd anticipated.
Jill as the last comment, and then Simon to finish, please.
Thank you. And just on the note of communications, of course, it's not just about communications. It's very much about proper engagement, not just patients understanding where we are, but they're co-producing our programs with us. So I was really pleased to see that there's communications training for staff in relation to making that happen, because I think staff historically have not had that training necessarily. I think newly qualified staff have more of that within their curriculum, but others haven't. So I think I'm beginning to see a real thread of real patient engagement, which is really encouraging. So thank you.
Thank you, Simon.
Yeah, thanks for all the comments. We've learned a lot over the last 6 months, and I hope that you can join with me in thanking everybody who has helped make some of those achievements possible, because there is a lot of hard work here that when it's summarised on paper, it's difficult to convey. And I think one of the things that I'd like to just come back to is, funnily enough, it's a point that you made, David, around ICANN. One of the things that constantly amazes me is how long it takes to do things. So we've been on with the ICANN conversation, for those of you who've been on with the full journey, for little shy now nearly of 2 years. It's taken us that long as a system to get it over the line. Even 6 months ago, I wasn't sure I'd be sitting here saying we've got an ICANN program and it binds us all together as a system. So the question which I'd invite you to take away, I suppose, other than joining me in thanking everybody who has contributed to this, is we can't afford to, in the future, particularly as people have said, working across the system, take another 2 years to find our transformation approaches and get them working not only in our hospitals, but also across the system, because the ICANN conversation, I think going back to your very first point, Denise, is really helpful, because there were real blockers in that conversation that took a long while to remove for all sorts of reasons. And we finally got it over the line in September, nearly 2 years down the line. So I just want to end there by reflecting on those 2 points. Thanks, but also I think we need to continue to focus on those blockers, and perhaps what we can do at CPC, Rachel, is to self-consciously bring that into view and just make sure that every so often we have a conversation about, are we really thinking about the factors that are inhibiting us, as well as the factors, as well as reporting on the progress. Thanks.
Okay, thank you, everybody. Yes, I have learned over the years that things always take longer than you think they'll take. And as you get older, some things seem to happen very quickly and some things seem to take even longer, and you get a longer time frame in your head. So I shouldn't be surprised about that. I just want to go back to the business of blockers and so on. When I have a slightly bad habit of using simple phrases to describe quite complicated things. So as you say, Simon, I've often said we can't even get into each other's hospitals. And it's easy to think about that as a car park or a pass. And that's quite important, because it's about dignity for senior people, for people on call and coming in, and we've been able to get into theatre to do their surgery, or to get into the car park and not be caught up in some sort of other problem. But it's also about not having to have your DBS check repeated. It's also about not having your pay conflicted between the two. It's also about not worrying too much about how the money is going to work as you move across that system and perhaps help the other hospital or whatever. It's also about discipline, grievance, behaviour policies, and how you do things. It's about Andy's business with digital sign-ins and similar systems and so on. So it's actually a really deep sort of comment that we have to do that. And that's about what removes. I mean, I have a long conversation with Stuart about car parks, which has obviously manifested itself in something meaningful between the two hospitals. And, you know, I think we've got to think about removing those cultural barriers and then getting people comfortable with being at the leading edge. And then we use the opportunity, the TIF money, to recognise the people who want to go further, faster, and develop that in line with whether it's the clinical strategy, the academic strategy, the estate strategy, or whatever. We must not be seen to be blown off course from those carefully thought through and crafted strategies. So, okay, thank you very much. That's pretty good update and a pretty good set of opinions on that. Group clinical strategy. Well, this has been a while in its gestation period, but that's a good sign. That's because it's been around the houses a lot, but it's very much been around our houses within the two trusts. It's been around our clinicians, it's been around our clinical senate, it's been around quite wide-ranging numbers of staff, and I'm sure at some point in this presentation, it's kind of led by Matt, but supported by Polly and Rabia, that we'll have a bit about the background and so on. But it's very important to understand this is our proposition, and this is about us thinking, okay, taking Jill's point, how do we now start to engage and communicate with? And it is more than communicate. We're not in the business of telling people now, we're in the business of listening to people after this one. So clinical strategy, over to you, Mr. Metcalf.
Thank you very much, Chair. And it is a great pleasure to be presenting alongside Rabia and Polly. And I'm sure colleagues will be delighted to know that even though a very generous 30 minutes has been allocated to this item on the agenda, and we are super excited about it, we will not be taking through a 125 page further, but rather trying to summarise the key highlights between us. As you've already mentioned, Chair, I'd like to take a moment just to appreciate not quite a cast of thousands, but certainly of hundreds of others who have contributed over the gestation of this emerging direction of travel and our ambitions for our clinical strategy. who have contributed, who can't all be here to present today, but very much it has been a joint effort. And shortly, Rabia will set out in a little more detail the extent of the clinical and indeed broader internal engagement that we've been through. It is very much our ambitions are woven through with those of our clinical leaders of both hospitals. Polly will also set out for us what, subject to the approval of both boards, what will happen next in terms of engagement externally in particular and with our patients, and also implementation internally. And suffice it to say now that we have experience from some vanguard services which have given us, certainly shone us a light on some of the practical details of how to do what we set out here as we proceed. One of those vanguard services, of course, is our ENT, our head and neck service, and I think I am the 5th person today to reference Bernadette's story. It's clearly imprinted on all of our consciousnesses for the right reasons and not the best possible delivery of care. I don't think any of us, despite the best of intentions of 2 hospitals operating separately, I don't think any of us would seek to defend or promote the model of care that requires a patient to be admitted to one hospital and then transferred at weekends to another. That hardly feels like a care pathway built around the needs of the patient. And of course, there are multiple other services where we cannot put our hands on our hearts and assure ourselves currently of equity of access to high quality, both in terms of outcomes and experience for our patients of care in the here and now. And Simon has already counselled us against being so wholly subsumed with the pressures of the here and now that we don't look to the future. And so this clinical ambitions document is very much a pitch on behalf of all our senior clinical leaderships, what we want for our patients, yes now, what we can do now, but also into the foreseeable future. And in its development, we have fully considered, whilst reviewing the case for change, the growing population and the aging population, both at rates which outstrip the national average, and have been acutely aware, because Rabia and I live and breathe it, the challenges in recruiting to certain specialties against a national context of skill shortages in those areas. And in that context, together with the support and indeed at times appropriate challenge of our clinical leaders, and the emerging and driving principle behind the strategic ambition we set before you today is that we, where it is necessary to drive up quality, we will consolidate into our hospital bases or when necessary into a hospital base, specific treatments and services. And equally importantly, where it does not have a quality impact and we can deliver the right quality of care, but improve the experience, improve the access of care to the population we serve, then we should be looking to disperse the services that we offer, both diagnostic and minor treatment, more broadly into the community. And so I think to try to condense those 125 pages into 4 key areas of focus as we seek to move into engagement and implementation, we'll be establishing 2 centres of excellence, building on services already, with cancer here in the west of the county at Northampton General Hospital as a centre of excellence, and cardiology in the north of the county at Kettering. The details of how excellence is defined is set out in the document, and has been stretched by our clinical leaders. And alongside that, we will consider what services can best be co-located, not just for interdependencies, but also for synergies that will enhance the quality and experience of patient care. So just to pick an example, by way of illustration, the radiotherapy clearly is delivered from the bunkers here at Northampton General Hospital. Prostate cancer is unfortunately increasing in its incidence, and the surgical treatment thereof is greatly facilitated by robotic technology, and so it will be sensible that we co-locate the robot on the site where the radiotherapy is delivered. We will, because our clinicians were very clear about it, and as was the East Midlands Clinical Senate, who have provided us with a degree of external validation of our strategy already. We will be creating ring-fenced elective beds, and we've already heard how imperative that will be in the H2 plan, but that we could fast forward that to the next 5 years, and the story is unlikely to change as we all come out of the COVID pandemic. And indeed, the East Midlands Clinical Senate were very keen, whilst praising the overall level of the ambition and the scope of the strategy ambition presented to you today, we're keen to highlight the need for integration with the integrated care system, and perhaps Karen might say a little on that as we move into the discussion. And that move into the ISA, move in working better with our integrated care system partners for sustainability, for equity of access, is something that we will be emphasising and developing further. There are some services we all know are and have been fragile, and we will move to consolidate those and build resilience into them, and very specifically take early steps to make single leadership across the group for those services. All of this strategic ambition, it does not stand alone. It is all in the frame of the Dedicated to Excellence strategy, and is enabled by the other supporting strategies. I'm not going to spend much time talking about the digital, people, and academic strategies, not least because two of those have further items on the agenda. But just to pick the academic strategy as an example, we know that for patients, centres that offer high research participation have better patient outcomes, and we know that for staff it's a real draw for recruitment and retention. So in summary, before I hand over to Rabia, from my perspective, I commend this strategic ambition to the board on the basis that it will make Northampton General Hospital, as part of University Hospitals Northamptonshire, a great place to receive care and a great place to work. Thank you, Rabia.
Thank you, Matt. I was just going to come back to where Rachel started, that how key communication in all of this is, and engagement along with it. And that has been pivotal in getting our clinical strategy to where it is today. And I know, Matt, you mentioned that hundreds of senior clinical leaders' opinions and voices have been involved. And alongside it, we also made sure that wider organizational voice is counted in our clinical strategy. So in summer this year, we conducted an organizational wide survey, just seeking opinion from our staff, clinical and non-clinical, in all the divisions, to see what they think of clinical collaboration, what their views are, and in their opinion, what impact they feel it will have on patients and themselves, but also seeking their opinion with regards to moving forward. What would they think would be the first things we should be focusing on? So that survey actually was, the results of it were very much in favor of the advantages of collaboration, which 87% of the respondents actually felt that the collaboration is something which will be very good for patient care, keeping in mind the reasons they gave was, we've talked about, is equity of services and maximizing on the potential we have across, and also addressing the staffing issues. What we, having done the survey on both the trusts, the plan was to do an initial survey at the start of it, but also do an interval one later on at the beginning of next year, and then keep doing interval surveys to see how that is. What that survey did was it gave us the voice of wider organization, but then that was reinforced by our various clinical forums at each individual trust, but also our joint clinical senates, which we conducted 3 clinical senates with clinical leads, and again seeking opinions and refining the ideas. And then those clinical leads then went on and spoke to their individual team. So quite a lot of engagement and communication at different levels, getting it to the stage where it is. And then in addition to that, obviously we did engage with East Midland Clinical Senate, and the expertise within the Senate panel was actually not just clinical, but non-clinical and layperson. So that gave us an external overview and perspective, and allowed us to address the opportunities which are in that ambition document. So from our point of view, the communication and engagement is something we really need to keep at the forefront. And it's slightly different from Vanguard services now, which are already on the journey, for example, ENT. So what we are also doing at the moment is carrying on the engagement with them, because they're the ones who are actually living the enablers and barriers and advise us a bit more. So accordingly, we are able to develop the plans as we move forward. And those engagements involve individual sessions with the teams on both the sites, but also I think the session Simon and the exec team has had on 100 days of ENT, that was very well received, because it allowed the team to talk about the barriers they have encountered, but also their anxieties and fears, which we were, and that has actually informed us how to move forward. So a lot of engagement and communication, absolutely cannot underestimate the importance of it in moving forward. So I will stop there, Matt, if that's okay.
Thank you. And I wonder if before we open the paper for discussion, I'd be grateful if Polly would give us some perspective on the next steps in the event that the board should support this direction of travel.
Happy to, Matt. Thanks very much. So for me, I think the next steps fall into 4 key areas, really. First of all, as you said, Matt, this represents what we think, what our senior clinical leads think should be our ambition to address our case of change, but we need to test that. So we need to go out to our local patients, our local public, and our stakeholders, particularly across the ICS, and ask them what they think about it. Help us to test it, prod it, poke it, make it stronger, make it more robust. So that's one way we'll test it. The other way is we'll start to do some more detailed planning. So you referenced the 2 centres of excellence, Matt, and we need to start to test what capacity do we need over the next 10 years to deliver that at Northampton, to deliver that at Kettering. What will it take to really be able to deliver those? And that for Northampton will then tie into then the development of what the master plan and the estate strategy needs to look like at Northampton as well. So that's a secondary piece of work that ties up very strongly to this one. So first one is testing what we think, what this document says in those 2 different ways. Second area is fragile services. So whilst this process has identified what our fragile services are, what we haven't got in this document is really how we're going to solve the fragility problem. So that's going to take some work over Q4 as well. That's going to take some work with partners, again, across the ICS, but also wider than that. So regional partners, out-of-county providers, tertiary providers, to understand what's our strategy to turn those fragile services into sustainable, reliable services that our patients can rely on. So that's the second area over Q4. The third area is, and Rachel referenced it earlier actually, through this process, one of the really positive things about doing this clinical ambitions document is that the clinical teams have really started to come together, not just in the forums that we've been setting up, the formal ones to do this piece of work, but actually coming together, linking up with each other anyway. And we need to develop and agree kind of a framework for them that allows them the permission and the ability to get cracking and talk to each other in a safe way that meets our obligations that we have on patient engagement and other things. So framework for ongoing clinical collaboration is the third. And the final one then is, we reference it in there, some of our priority areas for investment. And specifically we reference in there, and Matt, you mentioned it, a specialist cancer robot, the cardiac MRI, and developing a co-located head and neck estate on the Northampton campus. So again, we need to spend Q4 just putting some detail around what those are, working with John and his team in finance and the rest of the senior teams to work out how we can get those key investments moving forward as soon as possible in 22-23. So as a result of all of those, where we're hoping to get to at the end of Q4 then is a actual strategy. So this ambition document will turn into a strategy that's hopefully then been agreed with our patients and with our stakeholders and involves all of their feedback. We'll then also have implementation plans to kick off from April, both on the Centres of Excellence and on the fragile services, and of course on the investment cases. So that's the next 4 months, 3 months, 3-4 months of work as we see it. Thanks, Matt.
Thank you. I think that's our presentation finished, Chair.
Okay, thank you very much. This has been discussed in a number of fora, but it's still good to talk about it in a public board meeting. So welcome comments or questions or expressions of hope for what might come out of this. Over to you guys. Karen.
Thank you. I just wanted to add that this is obviously a real opportunity to transform and develop our services, as colleagues have already talked about, in terms of across the ICS, working with colleagues across not only health and care partners, but our local authority, our voluntary sector partners. We're developing the 4 collaboratives across the system around, and we've talked about ICANN, but mental health, and I think that really particularly relates to Amy's story we heard today. How can we really develop our services and link as part of that collaborative? So I just want to say, I know this is just offers us a real opportunity to come together with partners and to transform our services across the system.
Okay, thank you for that. Anybody else at all? Sharon.
I just wanted to add my support to the piece of work that that's been undertaken. I mean, clearly, huge amount of effort has gone in, and engagement with a wide range of clinical staff, nurses, midwives, and allied health professionals have been absolutely involved all the way. So there has been some really, really good clinical buy-in. And I know what we're saying around engagement with our patients, etc., but we need to recognise as well that indirectly we have been doing that, particularly because we've had such wide clinical engagement. We're not only hearing our staff's voice, but we're hearing as well what our patients are telling our staff. So absolutely agree that we do need to do a bit more public engagement on it, but I think it's a really well brought together clinical piece of work setting our direction for the future.
Andy.
Yeah, just to add my support for it, Alan. I think it's a great piece of work, helps set us off in the right direction and develops that ambition of what it will be like different for patients and staff as we move together as a group. So I'm really encouraged by what I've seen. Thank you.
Simon. Becky first. Becky.
Sorry, I just wanted to add my congratulations on the work as well. Such a lot of work from such a lot of people, and I think really exciting to see it nearly getting to the point where we can start to say what are the transformation plans off the back of this. And I know Polly and Karen and I have had quite a lot of conversations about how we can join everything up so there are coherent plans for services that encompass everything in the clinical strategy as well as all of the other transformation priorities for people. So you know, we're not asking people to do multiple things in different forums.
Heidi.
Thanks, Helen. Just to really acknowledge, I've come in obviously partway through this, and the hard work that colleagues have put into this to make sure we engage and really think broadly. But to Karen's point, I think it's important to note this isn't just about working across the 2 acute hospitals. This is about really transforming services to think about what their responsibility in acute hospitals is, for example, about health promotion to prevent people ever needing to come into hospital in the first place. So what does a centre of excellence really mean? There's a lot of discussion gone into that. So I just wanted to acknowledge that this isn't about simply bringing clinical services. The depth and breadth of conversation is really ambitious around our role as across the county.
Thank you. I don't see any other hands, so I'll give you Simon, which you usually go last, well, second last.
I think just to highlight three quick points for me. Firstly, to add my thanks to the work that has been done. It is 7 months in the gestation. Talking to that many people over that length of time is a considerable labour, and just on behalf of us all, again, I'd like to thank Matt, Rabia and Polly for getting us to the point where we have this document in front of us. The second thing, I just wanted to draw out one phrase from the presentation that you heard, and that was 10 years, because we are now proposing to chart a course for the longer term. This isn't about something that we do now or will be done in 2 or 3 years. This is something that will shape the course of acute services in Northamptonshire for 10 years. And I think that's a really important thing for us to bear in mind, because the choices that we make and the consequences that we put in place as a result of this strategy will have that longevity. And then the third flows from the second point, really, which I know you and I and Alan have discussed, which is the investments that we now make will follow this strategy. So we cannot continue to work in a world where we can do everything in all places. We are putting our ideas about where the stakes in the ground should be, and our investments in terms of services, in terms of resources, will flow from that. But I want to add my voice of commending this to the board to go out for engagement.
Okay, so that's pretty uniform support for this. I think we have a little balancing act to do here. We have an urgent exercise in meaningful engagement with our partners and our patients across the system for this. I think Heidi in particular makes a good comment that, you know, you really have to read this to get the full scale of the ambition of what a centre of excellence is. It sounds quite a simple concept, and it can easily be misunderstood as sort of nothing more than centralisation. So it is important that we have as Polly says, a major exercise in engagement. This is our plan. I recognise Sharon's comments that, you know, our staff are also our patients, but this is our plan. This is clinically driven, and it would be inappropriate, to say the least, in an integrated care system for us to decide that's the answer. So we have to engage broadly with this, and we have to be prepared to make changes on the head of that engagement. We have to find a way to make sure the patient voice is heard. Patients are no more willing to embrace change without careful thought than clinicians are. So we just need to think our way through how we do that. Having said that, the other side of that balancing act is we need to get on with some of these things. And some of them in the implementation and next step slide are probably those that point to the ones that we expect at least to have widespread support very quickly. And when we come to back to our previous conversation about H2 investment, people, TIF monies, so on, it is in those areas that we should be testing the support very quickly and be prepared to commit to well, I hesitate to say short circuit procurement processes, but you know what I mean in terms of going as quickly as possible within the rules for how we do what we want to do to start to show our clinicians who engaged in this process and our public that actually once you set this kind of strategy, things happen. It's not a bit of paper. In the same way as I'd like to think that Andy and Mark and John and Stuart and Polly and Karen look at it and say, when you set a strategy for what they do for the group, things actually happen. And that's what we've been talking about today, those objectives of the group and the strategy and so on. And we talked about we will talk about the digital and the academic strategy. So it's very important that we start to tread this balancing act. And I just want you to think very carefully about that. Rapid engagement, meaningful engagement, listen carefully to what people are saying. It's not a persuasion exercise, although there was a bit of that in it, but it is an engagement exercise. But also very quickly finding a way to say, yes, those bits are broadly supported. Let's move to show our clinicians that when we decide to follow a strategy, things actually happen. So well done, everybody. Good piece of work. It is actually, I'm told, the same gestation period as a hippopotamus. You can make what you want out of that. But a dangerous animal, large, scary, whatever. But it is, you can make what you want of that. But let's make sure we drive this forward, but listen very carefully as we do so. Okay, thank you very much. Thank you, Rabia. Thank you, Polly, for your contributions both across the piece and in the board. And thank you to everybody else who's commented on that in the process. Excellent. And thank you, Matt, for leading the conversation. Digital strategy update. Andy.
Thanks, Alan. So I'm just going to share my screen so we can see. I know that you've all looked at the paper, but I just want to highlight a few things. We've talked a lot, haven't we, today around what our group ambitions have been and the strategies that we've set and what's been delivered. And one of the things I said back at the clinical conference is when you've got a long way to go, it's easy to forget how far you've come. And I think today is a moment very quickly to just be able to look back and say, in the months since the strategy was improved, what has actually been achieved? And I think the strategy gives us a structure to be able to measure that. Many of you know there's 96 measures within this strategy, and that gives us a good way of measuring progress in a way that I need to be held accountable to. So in terms of the strategy, when we first agreed it, we agreed that we would do a review at 6 months. So this is very much that point. It's worth just clarifying the strategy has 8 points and 3 priorities within each of those themes, and none of those have been changed as a result of this review process. Really what's happened is in the bit of the detail around what's happened regarding the targets and updating the things that have been succeeded. In your pack, you will have actually the full strategy, which is marked up with any changes, and I don't propose to go into that, but it's there so you can see the full audit trail along the way. What I was going to do is just go through some of the themes and just pick up some key things that I think it's worth us noting as cause for celebration, really. So the way the pack works is there's the top part of it is the extract from the strategy as it exists, and then the bottom bit is a key updates that have happened since then, and then on the bottom right is the extract from our KPI tracker, the way that we manage and track all those 96 targets. So what I would do is just pick out a few things along each one, which I think are significant in terms of what's happened since we were agreeing this strategy back in March. So in terms of what we're doing for patients and families, one thing that is going to happen very, very soon is around the Patient Knows Best web. This is a patient front end, hesitate to use the word portal, but this is where patients will be able to get access to letters, to surface appointments, and even correspond with clinicians if we choose to enable that. And so what we're doing is a piece of work with advanced care planning and maternity to see how it gets used in practice and start to explore the possibilities of this platform. It's well regarded across the country, and there's lots of good examples of where people are using it, and patients are really positive about what they can use. So that's a really important element there. In terms of theme 2, I do want to mention it again, but moving over to NHS.net, all of us across the group, is a significant moment. We know that it's been a hard slog to get there, but we're there now. It allows us all to be on the same Teams platform. It allows us to share documentation, and as we move to everybody using Office 365, that again will increase the collaboration. And the other benefits of that start to be realized elsewhere. So we've talked a bit today about Power BI. So one of the things we'll do with Power BI is it will be the same NHS.net login as you use for mail to access Power BI. And that will start to become a theme as we work towards the single sign-on over the course of the course of the strategy over the next 2.5 years or so. And in terms of building that foundation, so we've continued to do more work in sort of building the foundations for our infrastructure. I was just reflecting this week actually with some folks from the KGH team around a period in September 2019 where we had 3 P1s. They're the most critical incidents. We had 3 of them in 1 month, and I look back at those as pretty bleak days. It's not to say we don't have any outages now, but I can look at the numbers and see that the performance and the quality of service is increasing, and we want to continue to make that happen. In terms of clinically led solutions, we've talked a bit about the electronic patient record program today in terms of the national funding approach, but perhaps what we haven't touched on is that in parallel to that process, we've still pursued making some more progress. So the electronic prescribing and medicine administrations project is still continued on, independent of that national funding, and the procurement's underway to deliver that, which is a key thing. It's part of our group strategy outcomes. It's will help with patient safety and the administration of medicine. So that's underway. And similarly, moving to electronic document management system, that will kick off in January at NGH and start to scan more records. At KGH, that's already made a considerable progress. So we're now at about 40% of inpatient discharges now use the scanned historical record. In terms of insight for decision making, we've talked about the firebreak and what that will mean for Power BI. And one of the first group positions at a service level is the appointment of a group head of health intelligence. Martin Inns will join us at the end of January. Really pleased to have him joining on. Will be part of this continued progress around how we use information to make decisions. And in terms of our view out into the system, a big moment this month will be the launch of the Northamptonshire Care Record. That will be providing GP data for point of care purposes. Things that we know that are really difficult for colleagues to get access to in a moment of need to support a patient will start to flow into that and be available. So it's a really significant moment. And as a consequence, the analytics reporting platform, the NARP, will also kick in. That will give us lots of capability to report at a system level, but also support some of the research aims that I'm sure Kay will talk about shortly, in that we've got this wealth of data that will start to be used in a safe and anonymized way for research purposes. In terms of the Connecting Our Systems theme, a big moment is around our Centre of Excellence. There's only 2 centres of excellence for robotic process automation in the country, and Northampton is one of them. We probably don't make, well, Tremaine certainly blows the trumpet about it, but we haven't talked about it, I guess, much at this board. This is a significant moment and part of building our reputation as a group that actually does innovative things and makes progress, both for ourselves, but on behalf of the NHS. And the other thing to note is, in parallel to the electronic patient records systems happening, there's already access to systems across the group. They are tactical solutions, they are a bit clunky, but there's a list of systems there that are already available for clinicians to use to do those group services. And I've already mentioned this, the single sign-on progress. And the final thing to mention is around how we come together. So we have commenced the, well, in fact, the consultation closed yesterday for the senior management structures across digital, and we'll move into phase 2 into the new year to get those structures, as we talked about, real signs of bringing folk together and removing the barriers that we might have between us, and releasing some of the efficiencies and improvements that we get by working as a single group. So I'll finish there. Certainly we're keeping an eye on the other strategies as they developed, and as we've talked about, as the clinical strategy works through, we're making sure that any changes that are necessary will be built into the digital strategy. And happy to take some questions.
Okay, thank you, Andy. Can you put the, thank you. Anybody want to pick up on that? It's we go through a regular process of updating on performance against strategies. So Matt, and then Jill, please.
Really just a note of appreciation and thank you to Andy for finding a silver lining in the capital availability issue and being agile enough to bring forward the implementation of EPMA and electronic pharmacy systems so that we can be fully deployed by March 23. From a patient safety perspective, I'm grateful for that.
Jill.
Thank you. Fabulous piece of work, Andy. And we don't reflect enough on achievements. We tend to be more pessimistic and look at what we haven't done. So I think it's fabulous. I'm particularly interested in sharing the systems with partners, because that will become more and more important, won't it? And I was pleased to see that System 1 is now accessible by KGH, and MGH is going live in December for stroke patients. Will that be rolled out for other specialties as well? So I know, for example, the palliative care team really struggle because they can't access System 1 at the moment.
Yeah, so the access to System 1 is quite a tactical solution. As the Northamptonshire care record starts to get populated with more information, that will be the source for that information. So we'll manage that transition, but the same information that's to be available in System 1 will be available to our clinicians this month, for a much wider cohort. We won't have to have all the overhead of managing multiple systems in that way. So it's a key event, and people have been looking forward to this for a long time. Simon's certainly been asking me about it on a regular basis as the deadline has drawn near. So it's a big moment and an important one.
Fabulous, thank you.
Simon, go on then, get on to him again.
Thanks. Firstly, well done to Andy. The second thing I'd just say is the point that you made, Jill, is really important about the shared care record and what insights it will start to give us. And just to remind colleagues, I think for the non-executive away day, there'll be an opportunity to consider some of the population health management and wider issues. I know Alan is keen for you and us to debate that. The third thing I'd want to say is just to remind everybody why strategies matter. One of the inheritances that Andy picked up that when he came in was the aggregation of 100 different decisions that had been made on a short-term reactive basis in both hospitals, the consequence of which has been enormously, and continues, we should be under no illusion, enormously tricky to unpick. So it's not only important to set a longer term course in terms of clinical services and how we organise them, it's as important to do it in a place like this, because the alternative is system chaos, by which I mean everybody has had their own pet system, but none of them end up being able to talk to one another in a way that is helpful to us. So let's keep the faith in terms of the longer term view on this.
Good. It's good stuff, Andy. Simple measures, really. After all this implementation and all this work, nobody's been banging on my door to complain. And that's quite important, because his history says that would happen in most major IT implementations. So it's good stuff. You've done well. Keep up the good work. The pressure does not get any easier. Trust me. Thank you very much. Academic strategy, Matt, and no doubt Kay as well on this one. But Matt, over to you.
Thank you, Chair. There's been a lot of talk, maybe too much talk about gestation so far in this meeting. But in this particular case, I think it's more about a strategy that we arguably gave birth to a year ago, when the strategy was approved formally by both trust boards. So on our first birthday, we thought you might like to see some of the academic strategies first steps, because we've been a little bit busy. I'm hugely grateful to Kay for bringing the strategy to life, driving it forward. And I'd like to hand over to her to present the 1-year update on the academic strategy across the group. Thank you.
Thank you, Matt. Absolutely delighted to be here and to talk about the progress that we've made as part of the academic strategy. Could we have the next slide, please? What I'd just like to refresh us is the objectives of the strategy, and we created 8 objectives through the strategy and the engagement that we did. And I think they could be grouped into a couple of areas. One is around our partnerships, in terms of our partnerships with our universities, and as you can see there, one of our main objectives was to become a university teaching hospital, which we clearly did in July of this year, which is a tremendous achievement for the hospital group. But this is about working across all of our research and our education, but also around some wider partnerships around estates and people and sustainability. The next area is about creating that culture, and particularly around research. It was mentioned earlier around, we know research active hospitals have lower mortality. It has an impact on recruitment and retention, but this doesn't happen overnight. For our workforce to have the right skills and the academic credibility to be research leaders of the future, they need master's qualifications and PhDs. PhD part-time takes 6 years, with postdoc support after that. So this is a long-term investment in that culture for us to be able to provide opportunities for people to become research active and to then become research leaders of the future. We'll do that through a mix of bringing in new talent and also developing our own workforce. We obviously want, from an education point of view, to provide the best possible placements for all of our clinical workforce, whether that's doctors, whether that's nurses, physios, dietitians, and we will look at technology enhanced learning and look at opportunities for multi-professional learning to deliver that really top quality placement across our hospital group. And of course, we need sustainability, and that's where the money comes into. So we obviously want to grow our clinical trials portfolio and grow our commercial activity, which brings in revenue. And we also want to increase the number of research grants that we will work in partnership with our university partners to bring additional research grants and income into the hospital group itself. Next slide, please. So the benefits of the academic strategy. So for our patients, if we've got a broader clinical trials portfolio, I hope that every single patient of ours can have the opportunity to have a conversation about, is a clinical trial suitable for them and their current disease profile that they've got. But that means to them they might get access to new treatments that wouldn't be available as part of standard care, which will obviously have an impact on their quality of life. We want to push the national Be Part of Research to help inform diagnostics and treatments, and obviously for our patients, been part of that learning culture where we're training the workforce of the future. It's a really healthy place to be, that those patients are contributing to new skills as we develop that future workforce. So for the workforce, we know that by being involved in research, it enables them to want to come here. It creates opportunities for them to work in partnership with our university partners. We can provide new career opportunities through clinical academic careers, where there are shared roles between our universities and also within our hospital group as well. And we want to support the, as I said earlier, about research active members of staff, so encouraging people to undertake master's degrees in terms of MRes, but also in terms of PhDs, whether we're funding those ourselves or access to regional and national funding opportunities that will allow that development. And of course, we want people to come to us as a hospital group through our academic strategy and the benefits that that will bring. So we will become an employer of choice, that we can match them with the opportunities that the larger university teaching hospitals in the big cities have. So for us as a hospital group, we know research active, as I said before, research active hospitals have lower mortality rates. We know by being a university hospital and having research and culture, that there will be improved recruitment and retention in our workforce. And through being part of research, that will obviously make an impact on the way in which we diagnose and treat patients, and the efficiencies that we will get that. And we're not just talking about clinical trials for drugs as well. We've got a couple of technology projects. It was mentioned earlier about Doppler. We've got a remote trial around Doppler, and that's really important to be looking at those future treatments for us as a hospital group, that we can rapidly be part of that testing and development and then subsequently adopt at scale across our group. And as I said, we want to be a hospital group that we've got a reputation, that we are providing contributions to new knowledge, new ways of teaching that future workforce, and to be really respected as a research leader. Next slide, please. So in terms of our roadmap, really, in terms of where we're going, we want to invest in our people, develop clinical academic careers for our medics, but also our MMAPs. And we've been really successful. We've got 3 NMAPs on regional programmes to develop as clinical academics, which is absolutely fantastic. We want to grow the Associate Principal Investigator scheme. So it's not just consultants who can undertake clinical trials. A key part of what we're going to be doing in terms of partnership with our university partners is looking at the National Institute of Healthcare Research infrastructure. At the moment, we don't have any of that infrastructure, and we've just put in some joint bids with University of Leicester to be part of a biomedical research centre and a clinical research facility. The BRCs, there was over £900 million of funding nationally that went to 20 centres in the last round of funding 5 years ago. This year, there's 26 bids, and we are part of that final shortlist with the University of Leicester, which will be a tremendous achievement for us to be part of that bid if Leicester are successful in getting their BRC next April. We obviously want to grow the income that we've got to help fund new posts and help support investment in our workforce. And I think really importantly, patient engagement. We want to ensure that our patients are given access to clinical trials, but also that the research that we do reflects the needs of the populations around Northamptonshire. And I'm part of the ICS, and I'll talk about that in my next slide, but it's absolutely important that we utilise our research to reduce some of those health inequalities that we're facing as an ICS within the county. We want to obviously grow research grants and grow the numbers of clinical academics and number of PhDs we've got across the group. And as I mentioned earlier, we want to deliver in a way that reflects the multi-professional teams that exist out clinically, and that we will then train in a multi-professional way, that it's not split by profession. And Andy spoke about digital transformation. We obviously want to transform digitally the clinical trials, what we do, quite heavily paper-based at the moment, and that makes us really inefficient. And to grow our commercial trials, we really want to transform digitally and to really engage with the EPR and all the benefits that can bring in terms of trial matching, to identify those patients who could be suitable, to enable us to bid for commercial trials and have the confidence we've got the right patient populations, and then efficiently recruit patients to those clinical trials. So can I just have the next slide, please? So our progress to date, as Matt mentioned, last year we approved the academic strategy and the business case, and we formally signed a partnership agreement with the University of Leicester. We then worked to launch University Hospitals of Northamptonshire in the summer. We established our academic strategy programme board that holds the delivery of that strategy to account, which then reports into the Joint Quality Committee. I chair a newly formed group, which is part of the ICS's Population Health Management Board, that is the innovation and research work stream, to have a look at how, as a county, we can embed research, we can connect people, we can bring more bids into the county. And we've been working with the University of Leicester to progress our clinical academic roles. So in August, we launched some funding to help our early career researchers, and we welcomed our largest ever cohort of medical students. We are going to grow those to an additional 50 by 22-23, and we've got stepped increases between now and then. And in September, as I said, we submitted some big NIHR bids with the University of Leicester, which will really radically transform our research credibility and give us additional opportunities to grow our research. We, in October, have expanded our research and medical education teams to support that increase in activity that we will get through new clinical academic posts in place and the growth in research active members of staff. So it's absolutely vital we had that investment in new members of staff to support that expansion. Next slide, please. So just a couple of points in terms of where we're at. I've mentioned we've had increase in medical student placements, our largest ever cohort, and we will increase that into 23-24. Research, we are obviously growing the number of commercial trials, and current performance to date at the end of October is 1,443 patients recruited across the group into clinical trials. We obviously want to grow that. Our baseline is around 2,000 for annual recruitment. I've mentioned about the people, and as well as supporting the clinical academic posts, just to mention that we want to grow honorary titles, which are recognised in terms of our academic credibility. So that's not only with the University of Leicester, but our clinicians will have honorary titles across the whole of the UK, and we want to actively support those relationships. But University of Leicester and the University of Northampton are our primary university partners. And our partnerships, we've really embedded and benefited from that partnership with the University of Leicester to help us achieve university hospital status. Those joint NIHR bids are going to be a game changer for us in terms of what we can offer. And in addition, we are working with the University Hospitals of Leicester to have shared governance for all of our research, and we will roll out common processes in April next year with UHL, and that will mean huge efficiency gains in what we do and really create a collaborative framework with University Hospitals of Leicester, University of Leicester, and ourselves as a hospital group. So hopefully I've given you a brief overview of the progress that has been made to date with the academic strategy. We've done all this in the backdrop of COVID. We've had to restart all of the clinical trial portfolio. We've had challenges with how we deliver our education training through reduction in space because we've classroom size, we've had to reduce the amount of students in there. But I think you'll agree we've made significant progress in the last year. This has all been about building our infrastructure and the foundations for next year, and to really start to ramp up our successes in terms of both from a research perspective and an education perspective beyond 22-23. Thank you.
Okay, thank you very much. Another update on the strategy, which is meant to deliver, and so it is. Any comments or questions about that at all? Yeah, Simon, and then Denise. No, I'll go the other way, sorry. I'll go Denise. You always go. Denise, you have to put your hands up quickly. Denise, Denise, and then we'll see where we are. Denise.
Okay, thank you. No, just a really quick comment. I mean, I love this strategy. I think it's really exciting. I think it's aspirational. I think it, encompasses a lot of the things that we're talking about. And for me, it's the key to ultimately driving a number of aspects of our overarching strategy and attracting really top class people to come and work with us. So the only thing that I would say is something that's been, just to echo something that's been raised a number of times today, we must make sure that we're communicating this internally and externally, because there's some really great stuff going on here. So thank you very much.
Simon.
Yeah, I mean, thanks, Matt, and particularly Kay, for the presentation today. Well done. A couple of quick points from me. The first is there's been a bit of a theme running through our meeting. These partnerships matter, and we need to invest the time in building them and growing them, because they don't happen automatically. The work that it's taken to get to what you've just seen in front of you today is 16 months worth of work, and still continuing. Kay drew attention to the fact that it's not just about the University of Leicester. There are other partners, the academic partners, that we need to get to, and I'm pleased to report that we had a very positive early meeting with the University of Northampton, and Alan and I have been invited to their board to consider how we can develop that partnership still further, because they have capabilities and assets that we can leverage, and they certainly, I think, would benefit from some of the things that we've got to offer as well. So I would just encourage people to say this will continue to evolve. And then the last point from me, perhaps looking back to the CPC conversation, as we go forward, I would really encourage board members, I think it was the point you made, Jill, to look at the joins between things. So you've seen 3 things this morning. You've seen our clinical strategy, you've seen this, you've seen the digital strategy. All of those link together. They should start to synergize, and we should be looking for opportunities to drive that synergy still further in the months ahead. Thanks, Helen.
Okay, thank you, everybody. Kay, I love enthusiasm, and you do enthusiasm in spades, really. So congratulations on that. Many years ago, I sat on the central R&D committee of the NHS for really quite a long time. I think I was the only person on the committee who didn't have a knighthood, actually. Just to make that point, really, in case anybody's noticing. But it was a very illustrious group of clinicians, and it taught me 2 things, really. One was the single biggest thing that can improve clinical services, clinical quality, is research trials. And if you're ever asked as a patient, you want to go on a trial, just say yes. And secondly, the power of clinical academic leadership. and I learned that in Cambridge, and I learned that in Nottingham. So this strategy is far more important than simply about building relationships with academia, or indeed with research or training. This is the thing that will almost certainly be most important in raising the standards of what we do across all our clinical professionals, and indeed possibly some wider groups as well. So well done. The progress is significant. We'll keep looking back on it and comparing it to the business case, but it's going extremely well indeed. Thank you very much for your presentation. Right, assessment and accreditation board approval for blue status. This is a background to the whole business of how we award the plaques really that sit outside the wards. So sometimes it's hard to remember. It's so long since some people have been in the hospital with infection control problems and everything else. But Sharon, take us through this.
Thank you very much, Alan. And I'm sure board colleagues will remember that we agreed in May that we would recommence our assessment and accreditation process. So following board agreement, we had refreshed our tool, and our lead nurse for quality assurance commenced the assessment processes. The agreed process that we have is when an individual area has scored 3 consecutive green scores, they then are eligible to apply to panel for blue status. Previously, we called it best possible care, but in line with our new vision, it's been renamed as dedicated to excellence. We were delighted that both Dryden and Althorpe Ward on their first assessment of the reset scored green, and taking on board their previous accreditation scores gave them at least 3 consecutive greens to allow them to apply for blue status. In accordance with our guideline, our review panel was set up. The panel consists of NED representatives, a hospital chief executive, representation from the CCG, from the university, from the voluntary sector, and a patient's voice as well. The ward manager and team were asked to speak to us and present their portfolio of evidence. And then following debate from the panel, we have asked to recommend to the board that both Dryden Ward and Althorpe Ward are awarded dedicated to excellence status. That is the request of the panel chair, that we could agree to that. If the agreement, I hope, will be in support, what we would have done if we were meeting face to face was that you would then formally present the plaque to the individuals who would attend that part of the board meeting. Could I ask though, as obviously they're not, we're not meeting in person and they're not present, that we could arrange then a face-to-face presentation to them at a suitable time when individuals are on site. So my recommendation is, please, that the panel's recommendation that Dryden and Althorpe are awarded dedicated to excellent status.
Are we all happy? Jill?
Thank you. I just wanted to make the point that this is a particular stupendous achievement given COVID and what all our workforce have been through. So, I'm in support of it and looking forward to building on the accreditation process that we've got at the moment as we go forward. So well done. I mean, through COVID to maintain 3 greens, really impressive.
Okay, Heidi.
Thanks, Alan. So to build on Jill's point, Jill and I were both on the panel, do support it, some great work there, but I just wanted to build on the point that Jill made. At the moment, we give blue status after 3 greens, and I've discussed with Sharon and Jill actually that we need to step that up in terms of making blue more ambitious than simply 3 greens. Now, I think those 2 would have met that anyway, but we are going to make sure that in line with the other ambitions that have been presented today, the pathway to excellence captures the breadth of the ambition that we're now aiming for as a group. So I just wanted to assure the board that those conversations are very live, but that doesn't mean that the content presented was absolutely excellent, as Jill said.
Okay, Thank you very much. You've not been here very long, Heidi, but you're learning the business of chairmen are never happy, and you have to keep raising the bar all the time to what's even vaguely happy. So I think that's a yes. Congratulations to Althorpe and Dryden. We'll arrange a time when we're in, Sharon, and we'll do it preferably with a few other people as well, and turn it into a little bit of an event, because it is a bit of an event for these wards. It's quite a remarkable achievement. So well done to them. Thank you very much. Thank you for your efforts. Right, Board Assurance Framework. Claire.
Thank you, Chair. This is the Q2 report, and it presents the risks associated with the delivery of the group objectives and those specific to NGH. Risks are assigned to specific committees, as you'll be aware, and they have all been discussed in month at these committees. Notable changes within the report this month are the score for the delivery of the academic strategy has increased based on the pressures on accommodation. The score relating to the nursing and midwifery professional strategy has decreased due to a reduction in the number of gaps in control, and the risks associated with finance, both on a group level, which is GS 108, and at the NGH level 115, have been reduced due to changes in the national finance arrangements. I'm happy to take any questions.
Okay, they've been through the due process and all the rest of it. Are you happy with the current scores? Yeah, okay. Fine, thank you very much for that. Freedom Speak Up biannual report. Claire again.
Thank you. This is the Q2 and the biannual report combined. In Q2, there were 14 cases reported, which is a big increase on the previous quarter, which makes it 19 in total for the half-year position, which is actually about right if we say there should be on average 10 per quarter if you think that numbers are appropriate. It's important to note that a number of staff did agree to meet with relevant executives to discuss the issues they raised, which has been really helpful in increasing understanding of these issues. The cases in Q2, the majority are linked to bullying and harassment and behaviours, and this remains the highest theme. Boards and the People Committee are aware this is always the highest scoring theme in terms of numbers, which is in line with the national picture and is an ongoing pattern. And these relate to attitudes and behaviour generally of line managers in these two quarters. All cases reported are then supported by HR and things taken forward through those with support from HR. The staff raising cases in this quarter has, for the first time, admin, clerical and maintenance staff have reported the most cases. It's usually nursing and midwifery because they make the bulk of our workforce. So that's just interesting to note. Also, to be mindful of equity of access to freedom to speak up. Locally, have started to collate, where possible, evidence of who has raised, which staff members have raised cases by ethnic minority groups, and to report that 6 of the 19 cases in the first 2 quarters, which is approximately 30% of staff, have come from an ethnic minority group. In the last 2 quarters, we now have trained 30 values ambassadors, almost half of which have been recruited from the staff networks, which is also important regarding equity of access. And also a key piece of work done with support from IT colleagues, and particularly Kieran, who's I know supporting the board, is the update of the intranet information. I'm happy to take any questions.
Okay, anything at all on that? I mean, it's not, I mean, it's not an entirely happy report, really, is it? It's all very well to say, well, it's in line with national figures and guidance. And I know when times are hard, the business of harassment and bullying becomes perhaps more a bit of a fine line debate between the right to manage and the perception by people. Denise, can I come to you anyway as chair of the People Committee and the Freedom Speak Up Guardian, or not Guardian, but oversight?
Yeah. Yeah, thanks, Alan. I think just to, I mean, I echo exactly what you've said, and that, you know, the whole issue around the bullying and harassment is something that that is a big focus. To hopefully provide some reassurance, I am meeting with Heidi in the next few days to discuss the sort of, well, firstly, what the thinking is around the new freedom to speak up guardian role, because obviously we will be losing Claire from that role. So I know Heidi's had some thoughts about that already. I see Heidi's hands up, so she'll probably elaborate. So I think, you know, we are meeting to look at that, but also to really look at how can the work that's already been done and the appointment of the values ambassadors, how can we really start to get to grips with the issues that we've got around bullying and harassment? Because it comes back to something that we were talking about earlier, that this has been on every single meeting since the very first board meeting that I had. So there's a blocker somewhere, and I'm not sure what it is. But also, it, you know, this is something that has a reputation. It has an impact both internally and externally, and there's so much other brilliant stuff going on that I think this is something we need to crack.
Heidi.
Thanks, Alan. So as you say, it isn't a report that we'd want to see. So firstly, I'd like to thank Claire, because she's worked really closely with me so I can understand coming in what the themes and trends are, what the focus areas need to be. So I'd just like to acknowledge that I've done quite a bit of work with Claire, and to thank her for that. But I think more importantly, this is far from where we want to be, and this comes down to some underlying basic values and behaviours, and it's been in the staff survey for some time at NGH. And so some of the things I've done already in terms of making sure that everybody recognises, particularly in the senior leadership team, and some really good conversations with the divisions about their responsibility to start making sure some basic behaviours are not accepted and not excused. But also, what does this mean for how we value people as individuals as a whole? So I think there's a number of angles around this in terms of there needs to be, it's quite a big piece of work in terms of underpinning basic values, but then there's the real focus in the areas that we need focus around where bullying harassment has been raised. So it's quite multifaceted. In the interest of the chairman's never happy, as you said, I'm really not happy with this. And so the ambition is high here. We need to get some capacity on the point that Denise made in terms of what's the plan for the freedom to speak up role. We need to make sure we're really going to be ambitious, be really focused in making sure we approach this from multiple angles, really. But having said that, there are some incredibly fantastic behaviours way support from teams, and so we really need to think about how we harness that and model that in how we move forward. So just to give you a bit of insight into my view on this at the moment.
Thank you, Heidi. I think that was pretty good. Andy.
Yeah, I guess I would say is, with all these numbers, you kind of say, well, is an increase in numbers good or bad? And I would say some of the work that's been happening within our staff networks, and my experience with the Reach network, is that there's more freedom to speak up ambassadors within that group, and that's encouraged people to feel more comfortable to speak. So, you know, I take some encouragement with this, that actually we're moving the culture on, that it is okay to raise these issues and make it part of you know, the conversation to improve the organisation. But so I guess that's my sort of tempering of the you know, looking at it from a downside.
Yeah, I agree with that, but of course there comes a point when it's not good news. So you have to have a balanced approach to it. Anyway, I think Heidi's contribution as the hospital CEO has been very helpful in that. I think we can take a lot of comfort from that. Okay, thank you very much for all of that. I don't see any other hands up. Thank you. Strategic Development Committee terms of reference. Can I just take those as read and approved? That's just making sure that our approach to estate development is across the piece now that Northampton is a bidder under HIP3, and we ought to be thinking both about how we state collectively, but also Polly leads the system estates committee. So if we can't get our act together, then it's hard to see how the estate system can. So this is about us coming together to think about strategic estates development, really. Are you happy with the terms of reference? Okay, thank you very much. I don't have any questions from the public. Do I have any other business from any of you? No, this is Claire's last meeting. She only slightly predated me, as I recall, for arriving in Northampton, and she steered us through some pretty tumultuous change, really, in terms of corporate governance and how things should be done. And at least one tricky CQC inspection, and looking back on Heidi's report today, quite a lot of other inspections, really, finishing up with health and safety. She's off to Birmingham, which has several advantages, the principal one being it's about a mile from her front door, and that is considerably better than travelling down the M6, which I got yet another, I say that unfairly, Claire, another text from you this morning saying there's a traffic jam on the M6 and Google Maps says I'm going to be late. So I wish you well with a 1 hour stroll to work and working with Dame Eve Buckland. I'm sure I see the hands, the obvious two hands are up to make other comments. So Heidi first and then Simon.
Thanks, Alan. So yeah, Claire has been crucial in my introduction to NGH, and I genuinely want to thank her both from the freedom to speak up perspective, but also from the governance, and as a really valued executive colleague. She's been incredibly helpful and informative of some really key things as I've come into the role, and really wish her well personally, because obviously it is much closer to her home, which is a key driving factor. So thanks, Claire. Can't thank you enough, really, for your support around the freedom to speak up role.
Thank you, Simon.
Yeah, 2 items from me, Alan. One, just to firstly formally record my thanks to Claire. In many ways, the testament to the work that she's done can be seen in the item that we talked at the top of the agenda on around the HSE inspection. What you won't all see is the labour is perhaps an understatement for it, that is required to navigate one of those inspections. You did that really well, Claire, and when we sat there at the end of day 1 and we were reflecting on it, I was really reassured to see you there. So I just wanted to say thank you. When we've done with that, Alan, I had one other minor item to report.
Carry on, one other minor item.
Just in the spirit of making sure the board hears this before anybody else, I've been appointed the NHIR Clinical Research Network Chair for the East Midlands. The organisation of that is the partnership group chair, essentially the board of the NHIR in the East Midlands, and that will be being announced in due course. So I wanted colleagues on the board to hear it before it was announced anywhere else. Thank you.
A multifaceted approach to our connection with research and development. Well done. Okay, thank you very much. Thank you, Claire. Can I ask you to pass the resolution excluding the representatives of the press and public due to the confidential nature of the business to be transacted? Yes, thank you very much indeed, in which case you now come off this link and there's a separate link for the private board meeting at 1:40, please. Thank you very much for your contributions this morning.